Hello and welcome. It is my pleasure to welcome you to the 2022 National Opioid and Substance Awareness Day event. My name is Scott Weiner, and I'm an emergency physician at Brigham and Women's Hospital in Boston and director of our opioid response program. We hold this event each year during National Recovery Month to both honor those we have lost to the opioid overdose epidemic and also remember that recovery is possible. We believe that every overdose death is preventable and that substance use disorders deserve to be treated like other medical conditions. The news this year is unfortunately not good. Despite so many efforts in learning to live and coexist with the COVID-19 pandemic, we still lost over 100,000 lives due to overdose in the past year. More must be done and can be done. And this is the spirit of our town hall event today. We're going to focus on the U.S. Department of Health and Human Services' newly launched 4 pillars of overdose prevention, which include the spectrum from primary prevention to harm reduction, evidence-based treatment, and recovery support. We'll also learn how buprenorphine and methadone, 2 of the FDA-approved treatments for opioid use disorder, work. We'll also discuss inequities in substance use disorder treatment and how to address them, and learn about screening and education resources. And most importantly, we'll hear from people with lived experience who are in recovery. New this year, we'll have a way for you to ask questions of the speakers. We also remind you of the many resources available on the opioidscreening.org website, including a free screening tool that anyone can take to determine their risk for opioid use disorder. You can start to ask questions of our panel a little bit later in the session, and you can write to the email address that I have on my screen, this side, which is 2022nosad@gmail.com. There are so many people to thank for putting this event together that it will be better if I don't attempt to name them all. However, I do want to give a special thanks to Dr. Douglas Jacobs, who conceived the idea of this event several years ago and has been an amazing partner, and Gloria Brand, whose team is doing all of the behind the scenes work of this program. And finally, our federal partners, including SAMHSA, ASPE, CDC, and others have been absolutely amazing in their collaboration. And now it is my great honor to introduce a stalwart supporter, not just of this event, but in so many initiatives to help those struggling from addiction. We welcome Mr. Patrick J. Kennedy, who will provide some remarks to open the occasion. As a representative in Congress, Mr. Kennedy was the lead author of the landmark Mental Health Parity and Addiction Equity Act, which requires insurers to cover treatment for mental health and substance use disorders no more restrictively than treatment for other illnesses of the body. As founder of the Kennedy Forum, he now unites advocates, policymakers, and business leaders to advance evidence-based practices and policies in mental health and addiction. In 2017, he was appointed to the President's Commission on Combating Drug Addiction and the Opioid Crisis, and currently serves as co-chair of the National Action Alliance for Suicide Prevention's Mental Health and Suicide Prevention National Response to COVID-19, and co-chair of the Bipartisan Policies Behavioral Health Integration Task Force. This is the second year that he has supported us in this event, and for that we are so grateful. Welcome, Mr. Kennedy, to give some open remarks.
Thank you so much, Scott, and thank you and Doug for just really pushing this conference over the years. And it's a real example of how leadership can make such a difference because, as you said, things are not getting better, they're getting much worse. But you've been out there really pioneering that we need to get in early because the real answer to this crisis is the prevention that we've never practiced across the medical system and society in general. I always say when we pass the Mental Health Parity and Addiction Equity Act, we just want to be treated like other disease groups. We want to have it inpatient in-network, outpatient in-network, inpatient and out-of-network, outpatient out-of-network, pharmacy benefits comparable, emergency room benefits comparable. We can really fight to end the separate and unequal treatment of substance use disorders if we compare them to how urgently we treat cardiovascular disease, diabetes, asthma, oncology. I mean, it is a real shame that you can go get your physical rehab and have them call you, set up meetings to brief you, hire navigators to, bring your family in, and no questions. But if you are needing recovery for a substance use disorder, none of those things are at play. And yet we have a federal law, and I'm happy to say we have that law now enforced by Department of Labor, which oversees over 80% of all insured lives in this country through the Employee Benefits Security Administration that labor oversees. And of course, our Secretary of Labor, as you know, Scott, is the former mayor of Boston, Marty Walsh, who's now really helping us move the enforcement of the Mental Health Parity and Addiction Equity Act forward. And I'm proud to say he's been on several events with us at the Kennedy Forum, where we host paritytrack.org and we host parityregistry.org at the Kennedy Forum. Our goal is to keep track of insurance denials, whether it be pre-authorization, concurrent review, retroactive review, whether we track the fact payers routinely pay much more for professionals in other areas of medicine than they pay for treatment providers of addiction. We just need to bring enforcement because as the great abolitionist Frederick Douglass said, power concedes nothing without demand. And we need to demand changes in this country. We still talk a good game, but we don't walk the walk like we in recovery are learning to do. I'm a person in long-term recovery. For me, that means I've not had to drink or drugs since February 22nd, 2011. And I was just with the President of the United States yesterday. He was up at the John F. Kennedy Library speaking about the cancer moonshot and using my uncle John F. Kennedy's moonshot speech as a call to action to end cancer as we know it. And when I had an opportunity to have a few minutes with him, I told him that addiction is the new cancer. That's where we need to really launch a bold initiative. It's affecting every family in this country. And we as a society need to do much more than we're doing. We write people off. And if you're not as fortunate as someone like me who can afford treatment, good luck trying to get it. That should not be the case in this country. And we have to end this double standard of care. And thank you for bringing up the issues of equity, Scott. We're seeing huge disparities in the COVID aftermath between Black and brown communities and their morbidity and mortality rates and those of the majority community. That's now translating also in the mental health and substance use disorder and the overdose rates, much, much higher, skyrocketing amongst Black youth particularly. We need to have culturally competent care so that our neighbors and friends and those in the BIPOC community can make sure that they get culturally sensitive care that understands impact of systemic racism, events like George Floyd, and the myriad of other vicarious trauma that they suffer on a daily basis. So I just want to say to everyone here, I always tell my own lived experience about how I was sober for a number of years, and then I had to go in for a emergency type procedure because I had injured myself, needed stitches. And I had told the nurse, they said, "What are you allergic to?" I said, "Opioids." And she chuckled at me because no one had ever said to her they were allergic. They'd say they were allergic to penicillin, but not to opioids. And frankly, when I was leaving after my sutures and the emergency room was very busy, they had given me a script because it's part of protocol to give me pain script after the sutures, and of course different doctors running around. And as we know in the EMR, Scott, we don't have the integration of mental health and addiction, and the notion that we have separate records for an illness as pervasive as this, with huge complications to those of us who have addiction if the wrong medication is prescribed, is unforgivable. And we need to change that. And Scott, thank you for leading this charge, because we have to make inroads with your house of medicine, because there aren't always those who are knowledgeable, even in the psychiatry community, about addiction per se. And all of this requires education, which is what you're doing today with these panels, is really getting literacy rates up so we can change practice patterns in this country once people are informed about really what's at stake here. So needless to say, thankfully, I have a spouse and family that actively support my recovery, and they interceded before I was able to fill that script. But that is another example. I had another procedure a couple of years later, and my health system still failed to recognize that I was a person in recovery and prescribe me opioids, forgetting the fact that by prescribing me opioids, they were potentially, doing the worst possible thing to put me in jeopardy for a very fatal illness. And we know now, because of the potency of fentanyl analogs, that when people relapse today, it is not like they would relapse 10 years ago when before we had these fentanyl analogs. They're dying. And I know this because I'm in 12-step recovery. I know of the number of meetings I go to where there are announcements made about our fellows who went out because of a relapse and never were able to come back because of the potency of the fentanyl out there. So we need to make sure we have medication-assisted treatment. We need to support the increase, if it is necessary, to deal with the increased potency of access to both the methadone and buprenorphine, among other things that we need to do. We need to do, kind of changes in the way of contingency management, which is a great source of evidence-based treatment that we rarely practice in this country. There's a lot of things, none the least of which is we need to understand how social determinants of health play a critical factor in helping provide people stability in their recovery. Because, of course, we do not have a recovery system in this country. We have an acute episodic treatment system, but we don't have a long-term chronic care management recovery system. And if we're to get that, we need to build these social determinants of health. And we at the Kennedy Forum are putting enormous pressure on the insurance industry because they're frankly unable to meet the requirements of the federal law. What we want to do is tell them, okay, we need to have carbon credits, carbon offsets. So if you're polluting through your lack of parity compliance, let's help you make it up by investing in recovery models of care. Let's help you build recovery care organizations like we had in Rhode Island when I was there as the congressman at Anchor Recovery up in Pawtucket, which absolutely transformed recovery in that Blackstone Valley. And we have all the hospital systems investing in it because they know it reduces the number of frequent flyers in our ERs. The payers are paying for it. We need to build that recovery system and really spread it around the country so that policymakers, both at the federal and state and local level, know what they can do to support recovery. That's going to require us to put together real manuals for public policy leaders to know what they can do. And so we're really working on that. And we'd love to continue to get a lot of support, I know, from people who are part of this webinar. So listen, thank you all for what you're doing. We have the 15th anniversary of the Mental Health Parity and Addiction Equity Act next year in September. And we have the 60th anniversary of the Community Mental Health Act, which President Kennedy first signed in '63. And we're going to look at the kind of true community model that would be commensurate with that vision that President Kennedy laid forth over 60 years ago when he said people with addiction, quote, need no longer be alien to our affections or beyond the help of our communities. And he wasn't talking about this being simply a medical issue, but medical issues need to be rectified. He was talking about communities, meaning people need support, supportive employment, because we know there are too many people who are outside our labor force today simply because they're not getting cared for their addiction. And this is an existential issue for corporate America to pay attention to, with the churn of so many employees year in and year out, and the fact that we don't have enough, able-bodied people in the workforce. We have to deal with this as an economic issue as well as a medical issue. There are so many reasons that we have to go forward, but It begins with the most simple, first do no harm, and then it goes to prevention and asking the same questions that we would ask if you were to come in, and your primary care doc would ask you, do you have a history of cancer in your family? Do you have a history of cardiovascular disease? I would say yes to both of those, but no one ever asked me, do you have a history of addiction in your family or mental illness? And I would have to say yes to both of those too, but it's never asked because we still stigmatize these illnesses, and that always has to be something we change. But I believe if we change practices like you're doing, Scott, through this webinar, what we end up doing is changing attitudes. Because like the civil rights fights, we haven't gotten rid of racism, but we've gotten very strong on anti-discrimination. And that's where we need to put our focus, is ending the embedded discrimination against people with these illnesses throughout our society, and particularly in our medical system and our insurance provider system. So with that, thank you very much, Scott, and look forward to staying in touch with so many of you. Thank you all for your advocacy. And for those who treat, those of us who are people with addiction, thank you for doing a very difficult job. But it's not just a medical calling. You're saving people's lives. You're saving their spirits. You're saving who they are as mothers and fathers and sisters and brothers. And I just want to thank you for doing the difficult. And you stick with it. And I thank you for sticking with us. And we want to help you so that you don't burn out, because we need you in this, because there are unfortunately so many more people suffering from these illnesses than ever before. And we need to do everything we can to support you in the job that you're doing. And so I know I rely on Scott and others to tell us what we need to be doing to increase the pipeline of future providers in the substance use disorder area. Just like we reimburse and we have loan forgiveness and all kinds of incentives for other medical personnel to go into their fields, we need to do the same in the addiction medicine space, because the need is so great and the services are so constrained. So thank you for those of you who are already doing this work. We really couldn't do it without you. Back to you, Scott.
Thank you so much, Mr. Kennedy, just for setting the stage for this forum, and more than anything for your courage, your profiling courage, from not just your advocacy and what you've done as a public servant, but also from, frankly, sharing your own story and your own experience, which carries so much power. We're going to hear a lot of these themes today. We're going to talk about the federal response. We're going to hear from providers that treat patients with opioid use disorder and other substance use disorders. We're going to hear from patients with lived experience as well, people with lived experiences, sorry, with the hope that we do reframe this and we make this something we talk about, similar to other medical conditions, something that we have appropriate resources for, because this is treatable. It's a treatable disease. So again, thank you. Thank you so much for your sponsorship, your support, your words, your advocacy, everything.
So Scott, you know, with HIV/AIDS, we were losing 54,000 people a year in '94, and we turned that all around. So now it's a chronic illness because the ACT UP community, the AIDS community would not have it any other way. Imagine the hockey stick and the death rate is going up. We need to turn that upside down, and we need to look at gaining recovery so people can have live and cope and not deal with this as a fatal illness, because we're paying attention and we're treating it proactively. That should be our goal. We can't get rid of addiction, but we can get rid of the way we're currently treating addiction so that not as many people die of it. So thank you so much, Scott.
Excellent. Thank you, Patrick. And with that, we'd like to shift gears to actually go to the part of our session which will be around the federal response. And with this, I'm really delighted to introduce Dr. Neeraj Gandotra. Dr. Gandotra is the Chief Medical Officer for SAMHSA, which is the National Substance Abuse and Mental Health Services Administration. Dr. Gandotra brings an incredible experience to the role, including as Chief Medical Officer for a nationwide addiction treatment network, serving vulnerable populations struggling from substance use disorders in Washington, Baltimore, and many other environments, in addition to too many other accomplishments and public service experiences to list. Welcome, Dr. Gandotra.
Thank you, Dr. Weiner, and also thank you, Mr. Kennedy, for your impassioned words, ongoing work in this area. I wanted to thank all of you for not only attending this conference. I think I was muted for the first moment. I wanted to thank Dr. Weiner for hosting this conference, Mr. Kennedy for your impassioned words and ongoing work in this area. As Chief Medical Officer of SAMHSA and on behalf of our Assistant Secretary for Mental Health and Substance Use, Dr. Delphin Brittman, I certainly want to applaud the work that's being organized today and thank the organizers of the National Opioid and Substance Awareness Day. I understand that the challenges thus far that have been placed have created an opportunity for us to be bold and creative in our endeavors to assist our communities struggling with the opioid epidemic. We like to describe SAMHSA as the behavioral health arm of HHS. We provide training, education through interactive webinars, publications, technical assistance for grantees, facilities, and anyone who calls, as well as the most important part, billions of dollars in grants towards substance use prevention and treatment through our state opioid response grants and our substance abuse prevention and treatment block grants. Through our state opioid response grants, what we commonly call SOAR, we provide states, territories, and tribal entities with funding for the treatment of opioid use disorder and stimulant use disorder. In coordination with the DEA and respective jurisdictions, SAMHSA has oversight over opioid treatment programs and the Data 2000 waiver providers prescribing buprenorphine, both of which are the gold standard of current treatment for medications for opioid use disorder. We know that without these medications, the overdose rates would be even higher. Our goal is certainly to help patients engage in treatment, but also reduce risk. To that end, we also understand that the majority of individuals with substance use disorder are not engaged in the treatment system. They are stigmatized, and those not in treatment are at higher risk for overdose. As a result of the overdose crisis projected to claim over 100,000 lives this year, HHS has developed and enacted a comprehensive strategy that my colleagues throughout the day progresses will detail. A major component of our challenge, as Mr. Kennedy's already mentioned, is stigma, as it prevents those from seeking care and at times discourages their engagement once they're in the healthcare system. The action to educate providers and communities is everyone's responsibility. I often liken addiction to some other qualities that we've seen as if it had its own life. Addiction thrives in the dark. This is where it lives because no one starts out with the goal that I want to lose my job, my home, my family, my health, my social standing, although that's where they may find themselves later once the addiction has progressed. Often it starts with, I want to feel good, as they may be dealing with trauma, pain, or other difficulties. Or it may start with a social interaction. But soon enough, the substance use takes over and it's no longer social. It's no longer to feel good. The focus of more and more activities are centered around obtaining, using, and recovering from use. The friends and family that are not using are avoided. And then the substance use is isolating them from the positive people who attempt to change this use pattern.
Dr. Gandotra, sorry to interrupt. We lost your video.
Oh, I apologize. Sorry.
There we go. Thank you.
Sorry about that.
Sorry to interrupt.
And what happens is the substance use disorder is trying to survive. It can't survive when light is shown upon it, when it's demonstrated to be incompatible with the person's goals, with their survival. But when the substance use is active, that person retreats in the dark. That social circle is then only involving individuals who may be using. The person is no longer taking the substance to feel good as they were once dependent. And more importantly, they are in the dark. They feel stuck. They're feeling withdrawal and now only want to relieve the withdrawal. They want to stop feeling bad. But stigma keeps them from seeking help. We all need to work to reduce the stigma by shining light on this problem. Certainly preventive efforts are going to be highlighted, but we also need to talk about, educate, fund, and model destigmatizing language to facilitate engagement. So you're going to hear a lot from the primary pillars of our prevention strategy. Primary prevention with opioids, describing the first step of the problem, bold harm reduction efforts that meet the patient where they're at, and more importantly, demonstrate that recovery is necessary for basic survival and fostering further engagement. We have to keep them alive first. In describing the overdose prevention strategy, we hope to educate all stakeholders that recovery is not only possible, but sustainable. As an example of our commitment, SAMHSA funds our Peer Recovery Center of Excellence, which is a resource to individuals, organizations, and systems working to advance successful implementation of peers support recovery models within recovery across an array of settings. I'd also be remiss not to mention that this is also National Recovery Month, and September, as well as all year long, SAMHSA strives to support recovery for every person, family, and community. And to increase awareness, SAMHSA has developed resources to help all Americans improve their health and wellness as they get to lead more successful lives. We certainly have a wonderful program highlighted by speakers across the department, starting with Dr. Tisa Marie Sherry, who will be discussing the overdose prevention strategy. Dr. Tisa Sherry is the Deputy Assistant Secretary for Behavioral Health, Disability, and Aging Policy in the HHS Office of the Assistant Secretary for Planning and Evaluation, or ASPE for short. She will discuss the overdose prevention strategy in more detail. Dr. Sherry.
Thank you so much, Dr. Gandotra. And I want to thank Dr. Weiner and his wonderful team for putting together this important conversation. I want to thank Mr. Kennedy for starting us off with such powerful reflections. And also, I'm so honored to be able to participate with such an esteemed group of panelists today, including people with lived expertise. I'm delighted to be here on behalf of ASPE. ASPE is the principal advisor to the Secretary of HHS on policy development. We coordinate the department's evaluation and research activities, and we lead the development of the department's legislative agenda and also lead special initiatives. One of these, which I'm excited to discuss with you today, is our HHS overdose prevention strategy, which was launched nearly 1 year ago. Next slide, please. Briefly, I have no relevant disclosures or conflicts of interest to report. Next slide. Now, addressing substance use disorders has long been a priority for HHS, where we've made significant investments. But department leadership under the Biden-Harris administration recognized the need to refocus and reinvigorate our efforts in response to the evolving landscape of the substance use disorder crisis. Now, first, as this chart shows, the acceleration in overdose deaths over time, and in particular during the COVID-19 pandemic, demands a more comprehensive all hands on deck approach. It also requires that we adapt our responses to the changing drug supply and the increasing prevalence of more potent synthetic opioids. Between 2000 and 2020, synthetic opioid-related overdose deaths have increased by more than 5,800%. Now, second, the other feature of this evolving landscape that we've been tracking is that whereas previous HHS strategies focused primarily on opioids, the evidence indicates that in recent years, the overdose crisis has also been characterized by increases in stimulant and polysubstance involved deaths, as also shown in this chart. Between 2015 and 2020, overdose deaths involving cocaine nearly tripled, and deaths involving other psychostimulants increased fourfold. Next slide, please. This data on drug seizures by Border Patrol also illustrates the evolving nature of the crisis. For example, since the fiscal year of 2014, we've seen stark increases in seizures of methamphetamine, cocaine, and fentanyl. And so in response to this evolving landscape, one significant shift in the HHS strategy has been going from a narrower focus previously on primarily opioids to a broader focus on overdose and the diverse strategies that are needed to address polysubstance use. Next slide, please. Now, a third key feature that has motivated our approach is that there remains stark inequities in the distribution of overdose harms and access to treatment that in particular disadvantage people living in rural areas, people from minoritized racial and ethnic backgrounds, pregnant people and parents, and other historically underserved groups, as highlighted earlier by Dr. Weiner and Mr. Kennedy. To illustrate the need and challenges in rural areas, this map highlights counties with the highest need for opioid use disorder treatment in dark green as of 2018. More than half, about 62% of these highest need counties are in rural areas. Yet the majority of the highest need counties in the US have inadequate capacity to deliver buprenorphine to patients in an office-based setting. Next slide, please. In recent years, there have also been marked increases in overdose deaths among people of minoritized racial and ethnic backgrounds who are also more likely to face barriers in accessing equitable treatment and recovery services. As this chart illustrates, despite similar rates of behavioral health disorders to other racial and ethnic groups, Black Americans have substantially lower access to treatment services, with nearly 90% of those with a substance use disorder reporting that they have not received treatment. Next slide. We observe similar disparities, unfortunately, among Hispanic Americans, and alarmingly, these gaps have been widening in recent years. Therefore, HHS feels that there can be no effective response to the overdose crisis that does not explicitly emphasize the imperative of eliminating disparities in treatment and recovery services. Next slide, please. Next slide. Thank you. Now, based on these changes in the drug overdose landscape, HHS released last year a new overdose prevention strategy. Experts across the department came together to leverage the best evidence to prioritize 4 key target areas for the strategy: primary prevention, harm reduction, evidence-based treatment, and recovery support. Now, we recognize that all of these priority areas are indeed a continuum, and there are a number of interventions that don't necessarily neatly fit within one bucket or another. But what we believe is most important is that our response be comprehensive and represent the full continuum. Each of the 4 priorities also incorporates 4 cross-cutting guiding principles. These include emphasizing equity, leading with data and evidence, increased coordination, collaboration, and integration to break down the silos that have so often impeded our response to the substance use disorder crisis, and importantly, reducing stigma. Within each of our priority areas, the overdose prevention strategy lays out 4 objectives with associated activities. We have 44 in total currently. These high-impact featured activities are not exhaustive of all HHS activities underway to address overdose, but they are some of the key select ones that we highlight. Additional activities will be added to the strategy over time, and outcomes associated with each activity will be measured regularly to assess progress. Next slide, please. A few additional highlights of the strategy. The first is that we try to take a comprehensive focus across the entire lifespan, and also focusing specifically on the intergenerational impacts of substance use disorders as they affect families. We also emphasize representing the full continuum of care and services integrated across not just the healthcare sector, but also other sectors such as human services and types of care across multiple different settings. Consistent with the Biden-Harris administration's emphasis on equity, our overdose prevention strategy also emphasized the importance of advancing evidence-based policy that is equitable and inclusive of all populations affected. The strategy is also novel in its emphasis on harm reduction and recovery support, which are critical elements that have not been previously emphasized in other strategies in the department. The strategy also prioritizes translating research into equitable practice so that we can close the gap between the data and evidence and what we're actually seeing being offered in practice. And finally, we have made substantial investments as a department to back up this vision. In fiscal year 2022, initiatives associated with the overdose prevention strategy totaled $11.2 billion, which represented a 54% increase over the prior fiscal year. Next slide, please. Briefly, just kind of keeping an eye on time because I want to make sure to get to our esteemed panelists. I'm just going to walk through and highlight at a high level our 4 priority areas. So first, for primary prevention, we have 4 objectives: to support research and surveillance to develop and improve delivery of prevention interventions, to facilitate the implementation of evidence-based primary prevention across the lifespan, to support the development of and promote evidence-based treatments to effectively manage pain, and to reduce clinically inappropriate prescribing of medications with abuse or misuse potential. You'll be hearing further about this from my colleague, Dr. Grant Baldwin of CDC, who was also instrumental in helping to inform this strategy. Next slide, please. In our harm reduction priority area, objectives include to advance research and demonstrations on innovative harm reduction approaches, to promote evidence-based harm reduction services, including those that are integrated with healthcare delivery, to expand sustainable funding strategies for harm reduction, and to develop educational materials and programs to reduce stigma. I'm so delighted that you will hear from Dr. Monica Burrell about this. Dr. Burrell is actually the one member of the panel who is not currently a federal employee, but she brings the vital perspective of state and local efforts to address harm reduction based on her wealth of experience, which I think is critical to informing our discussion here today. Next slide, please. For evidence-based treatment, our objectives include supporting research on and development of new treatments and strategies to improve engagement and retention in care, broadening access to evidence-based care that increases willingness to engage in treatment, increasing the uptake of evidence-based treatment delivery that improves engagement and retention, and promoting evidence-based integrated care for people with co-occurring conditions across lines of service and care settings. In this area, you'll be hearing from my colleague, Dr. Ingvild Olsen of SAMHSA, who has also been a key partner in developing this strategy. Next slide. And finally, last but certainly not least, is recovery supports. Our objectives here include enabling access to and encouraging the use of integrated recovery support services, improving the quality of coordinated recovery support services, strengthening the recovery support services workforce, and researching and identifying best practices for recovery support services and strategies to sustain these services. Here you'll be hearing from Donna Dimitrovich from SAMHSA. Next slide, please. Now, in terms of our next steps, the evolving nature of the overdose crisis demands a dynamic and bold response. So we will be closely monitoring the implementation of the overdose prevention strategies activities over time to assess our progress towards addressing the overdose crisis, but also in identifying gaps where we can continue our work to fill them. And we will be adding new activities to address those gaps. In addition, on our OPS webpage, which is our constantly updated source of information on the overdose prevention strategy, we'll be listing HHS research and highlights, and also adding key accomplishments. A number in the past year, just since the strategy was launched, include the new draft CDC prescribing guideline on opioids, the purchase of fentanyl test strips by our HHS grant programs, the expansion of SAMHSA's National Harm Reduction Technical Assistance Center, and many more, which will be highlighted in our forthcoming one-year anniversary of the overdose prevention strategy. Next slide, please. Our website is here for those of you who would like to follow along and take a look. Next slide, please. And that is all from me. Thank you so much for the opportunity to be here with you all today. And with that, I'm delighted to hand the mic back to Dr. Weiner and our panelists.
You're on mute, Scott, but do you want me to go ahead and get started?
That's just what I said. Thank you so much.
Great. Thanks, Dr. Weiner. Thanks, Dr. Sherry. Hi, everyone. My name is Grant Baldwin. I'm the director of the Division of Overdose Prevention here at the CDC. Obviously, it's a real pleasure for me to be here. I'm going to dive a little bit further into the primary prevention pillar. Obviously, prevention is really critical to reducing overdoses and overdose deaths. This strategy in the overdose prevention strategy promotes tiered, multidisciplinary prevention activities, ranging from population-level strategies really to targeted interventions aimed at high-risk individuals. As Dr. Sherry mentioned, there are 4 overarching areas of investment for primary prevention, and they include, just to reiterate, to support research and surveillance to develop and improve delivery of prevention interventions, to facilitate the development and implementation of evidence-based primary prevention activities really across the lifespan, to support development of and promote evidence-based treatments to effectively manage pain, and finally, to reduce clinically inappropriate prescribing of medications with abuse and misuse potential. Of course, given my affiliation with CDC, I'm going to focus my remarks on some of CDC's signature contributions, the flagship programs of Overdose Data to Action and our Drug-Free Communities program. I'm also briefly going to discuss our Stop Overdose campaigns, and as Dr. Sherry mentioned, the soon-to-be released 2022 CDC clinical practice guidelines for prescribing opioids for pain. So now more than ever, the integration of data informing action is essential because of the potency and rapidly shifting illicit marketplace that you've heard about. CDC funds 66 jurisdictions as part of our Overdose Data to Action program, or OD2A, as we like to call it. That's 47 states, DC, and 2 territories, as well as 16 big cities or counties. This is a $300 million program a year for 4 years. Of course, we need more timely and comprehensive and localized and actionable data. And we need to create data that is sought after, easily accessible, and readily used. We need to do this both for morbidity and mortality data, and that's exactly what we do with our dose and suitors programs. OD2A now also encompasses a larger breadth and depth of prevention strategies, so prescription drug monitoring programs, state and local integration, which I'll talk a little bit more about in a second, linkage to care, provider and health system supports, public safety partnerships, and many more. Overall, states receive anywhere from between $2.5 and $7.5 million in funds, with a tremendous amount of flexibility intentionally to tailor what they do and give them the freedom to test out new evidence-informed prevention strategies. I will also say at least 20% of funds need to go to the local level to spur innovation and to support multi-sector collaboration. This program runs through August of 2023. We're in the process of reimagining what that program is going to look like going forward. With a modest investment of just $125,000, the central aim of the Drug-Free Communities program is to utilize community-based coalitions across 12 sectors, including schools, businesses, the faith community, and youth-serving organizations to organize to prevent youth substance use and initiation. The DFC program includes a community match requirement to further entrench commitment and buy-in, and a community can be funded for up to 10 years. It was launched in 1998, and has grown substantially and has impacted over 2,000 communities over the life of the program. There were almost 750 community coalitions last fiscal year, and 1 in 5 Americans now live in a DFC community. In the fall of 2021, we launched 4 new evidence-based communication campaigns to prevent and reduce drug overdose in young adults ages 18 to 34 under the banner of Stop Overdose. The campaigns address the risks of polysubstance use, the dangers of fentanyl that you've heard about, the life-saving power of naloxone, and stigma around treatment and recovery for those experiencing a use disorder. We've had remarkable uptake with this program, delivering more than 1.3 billion impressions and 605,000 click-throughs on this content in 2022 alone. And finally, CDC anticipates, as was mentioned, releasing the 2022 Cdc Opioid Prescribing Guideline later this fall. It expands and updates the 2016 guideline. It features a broadened scope, so including acute and subacute as well as chronic pain, updated and specific information on non-opioid treatments, expanded information on opioid tapering, and new elements to help avoid its misapplication. It provides 12 specific recommendations for clinicians prescribing opioids in outpatients aged greater than 18 years old with pain outside of sickle cell disease related pain management, cancer pain, palliative care, and of course, end-of-life care. Of course, the recommendations are voluntary, and patients living with pain, of course, deserve safe, effective, individualized, and informed pain care. And the 2022 guideline aims to ensure equitable access to pain management that improves individuals' function and quality of life while clarifying and reducing risks associated with opioids. With that, let me turn it now over to Dr. Monica Burrell to discuss the harm reduction pillar and her amazing work in Massachusetts.
Thank you so much, Dr. Baldwin, and thank you all for having me here today. My name is Monica Burrell, and I am here to focus on the second pillar of the HHS overdose prevention strategy, harm reduction. In my recent roles as the Commissioner of the Massachusetts Department of Public Health and a Senior Advisor to the Mayor in the City of Boston, addressing the opiate epidemic was a central part of my work. The HHS overdose prevention strategy emphasizes implementation of this framework based on federal, state, and city governments working together with healthcare, communities, law enforcement, and other stakeholders. I have found that this collaboration is key to driving improvements in access to life-saving harm reduction tools, and I'll spend my time giving you some examples of that. First, as we all know, harm reduction is a set of principles and strategies to reduce the negative consequences associated with drug use. For me, at its heart, this is about meeting people where they are with deep compassion, focusing on the individuals and communities we're here to serve. And as stated in the overdose prevention strategy, individuals inherently deserve services that promote health, regardless of whether they use drugs. The first objective in the harm reduction pillar is about advancing research and demonstrations on innovative harm reduction approaches. Having an evidence-based toolkit to address SUD and harm reduction through an equity lens is critical. For many reasons, including stigma, there are gaps in our knowledge. To fill this gap in Massachusetts, we built a public health data warehouse to bring together data for the first time from across 20 different agencies to create a more holistic picture of who suffers from SUD and what they need. We gained deep insights, including the populations who are at highest risk for overdose, and we use these insights to improve our programs and policies. This took collaboration across government branches, academic partners, healthcare providers, and public health systems. The second objective under the framework is to promote evidence-based harm reduction services, including those that are integrated with healthcare delivery. One area to reduce harm is in the misuse of prescription drugs. You've heard a little bit about this already. And in Massachusetts, we revamped our prescription drug monitoring program and saw a 40% reduction in Schedule II drug prescribing. This was done with a partnership across government, education, clinical, public health systems, and individuals with lived experience, both of substance use disorder and chronic pain. This third objective is about funding. And we do not want to continue to go from pilot to pilot, but we want to all together be able to build and scale sustainable solutions. When we have the evidence, we need to find ways to scale those interventions. This takes creative use of funds. One way we leverage funds for our work in Massachusetts is by developing and using a shared roadmap. We use the recommendations from our governor's opioid working group, where they had over 60 recommendations set forward to address the opioid epidemic. This included harm reduction measures such as access to naloxone, expansion of comprehensive safe syringe programs to include HIV services in connection to treatment and primary care. These recommendations were then able to assist our legislative and executive branches to prioritize funding, set up trust funds, and find ongoing funding mechanisms. The recommendations were based on input from those with lived experience, families and communities, community-based organizations, healthcare, public health, political justice, political leadership, criminal justice, and business partners. So therefore, we were able to have a consensus around how the fund should be used. The fourth objective, and in some ways the most important, is around developing educational materials and programs to reduce stigma. In Massachusetts, we developed the Stop Stigma campaign, seeing addiction as a chronic illness deserving intervention and treatment. And the campaign's success was based on featuring individuals in recovery and individuals with lived experience. The framework that we're talking about today emphasizes innovation based on community engagement and equity. In Boston, we listened to individuals experiencing unsheltered homelessness who were using substances and asked them what would help them get out of the tents that they were staying in and into safer and healthier housing. One key request was a place focused on harm reduction, meeting them where they are. So we built that. We included skilled staff who were trained in harm reduction, services including naloxone availability, and access to holistic services on harm reduction, behavioral health treatment, including medications, medical care, and access to housing. This took a true cross-sectional collaboration between housing, public health, public safety, community, and those with lived experience. Again, an example about how cross-sector collaboration will allow us to make the improvements we know we need that are evidence-based. We can improve outcomes for our patients, families, and communities by following these evidence-based harm reduction models and centering our care around acceptance, compassion, and high-quality clinical services. Thank you. I'll now pass it on to Dr. Olson, SAMHSA.
Hi, good afternoon, everyone. Thank you so much. My name is Dr. Ingvild Olson, and I am the director for the Center for Substance Abuse Treatment. I'm also an addiction specialist physician and a general internist by training. And so to focus on the evidence-based treatment pillar of the strategy, I want to just highlight that it really recognizes 3 key points. So the first is that we have highly effective medications that reduce opioid-related overdose mortality by over 50%. And while we do not have such medications for stimulant use disorder, we do have effective interventions such as contingency management that has been shown to really be able to help people reduce their use of stimulants and achieve recovery. But the gap in access to and utilization of both of these very highly effective and evidence-based treatment interventions is enormous. And there are lots of different reasons for that, some of which relate also to stigma that you've heard about. So the activities in this pillar are really designed to reduce barriers to access using motivational and cultural enhancements to encourage those who might be reluctant to provide these interventions or take them. Advance strategies to improve engagement and retention as we move forward. Now, that you already heard about from Dr. Sherry that are at incredibly high risk for overdose mortality. And that includes people of color, as you've heard, people involved in the criminal justice system, those who have co-occurring disorders, and adolescents and youth, as well as pregnant and postpartum individuals. And particularly when we look at the intersectionality of all of those, we see even higher overdose mortality risks. So with that, the 4 broad areas that Dr. Sherry mentioned, and there are many activities in each of those areas, too many for me to really go through all of them. So I'm going to give you an example of each. The first area supports research on and development of new treatments and strategies to improve engagement and retention and care. So the example here that I'd like to highlight is the National Institutes on Health Helping to End Addiction Long-Term, or HEAL initiative. You may have heard about this because Massachusetts is one of 4 states that is a part of this very long-term large study. The HEAL initiative is a longitudinal study that is testing a set of proven prevention and treatment interventions in 67 communities across 4 states that have been particularly hard hit by the overdose crisis. What is unique about this study is not only its breadth and size, but also that it is implementation science and community participatory approaches really at all levels of the study. The HEAL initiative also has a component that includes both NIH as well as the Department of Justice that is focusing on the criminal justice population. Now, the second area broadens access to evidence-based care that increases willingness to engage in treatment. An example that I'd like to highlight here is that the opioid treatment program flexibilities that were initially promulgated by HHS and SAMHSA in response to the COVID-19 pandemic really has ushered in a significant change in access to methadone take-home medication for people with opiate use disorder. And we have heard and seen through research, as well as anecdotal evidence through stakeholders, states, localities, individuals who are receiving the services, and their providers, that this has been incredibly well received and very safe and effective. Now, SAMHSA has extended these flexibilities to allow for more time to make permanent some of those flexibilities as well. So we want to make sure that we can learn the lessons of the last couple of years to make sure that we can make access to treatment and engagement as accessible and equitable as possible. We do know that 43 states and the District of Columbia have taken advantage of those flexibilities since March of 2020. The third area seeks to increase the uptake of evidence-based treatment delivery that again also improves engagement and retention and care. And the HHS buprenorphine practice guideline is what I wanted to highlight here. This was released in late April of 2021, and it allows practitioners with an existing DEA registration to forego the necessary training that is typically required by law to obtain a waiver to prescribe buprenorphine to up to 30 patients with opiate use disorder at a time. This also is a tremendous change in how we deliver medications and how we support the practitioner care for individuals with opiate use disorder. To date, over 16,000 practitioners have taken advantage of that opportunity. And across the country, we now have over 130,000 eligible practitioners to prescribe buprenorphine for the treatment of an opiate use disorder. And then finally, the activities that work to promote evidence-based integrated care for people with co-occurring conditions across lines of service and care settings is the fourth area that I wanted to highlight. And I don't want to speak for Dr. Baldwin from the CDC, but I did want to mention a CDC initiative called the Combating Opioid Overdose Through Community Level Intervention Efforts. This is an effort that is supporting pilots in high-need areas to link people to care post-overdose using patient navigators and recovery coaches, as well as initiating buprenorphine in the emergency department. So this is just a smattering of the initiatives really in this pillar. There are more initiatives in this pillar to come. And I'd encourage you to really visit the HHS Overdose Prevention Strategy website that Dr. Sherry highlighted for more information, more on the strategy and this pillar and these activities. And with that, I'm going to turn it over to my colleague and friend, Donna Dimitrovic.
Thank you, Dr. Olson. It is my pleasure to be here today. My name is Donna Dimitrovic. I'm a senior advisor in the Office of the Assistant Secretary working on initiatives around recovery. And I also am a woman in long-term recovery. God willing, October 14th, I will be celebrating 37 years of continuous recovery. So this is really a topic that is near and dear to me. And as Dr. Sherry highlighted the overdose prevention strategy, I'm going to talk about recovery supports and the work that we're doing at SAMHSA, really to enable access to improve quality of recovery support services, as well as strengthen the workforce and talk about some of the work that we're doing at SAMHSA around recovery. So I think the first thing that I wanted to do is really talk about the definition of recovery. So in 2010, SAMHSA brought together leaders in the mental health and substance use communities to develop the definition of recovery. And just recently, we hosted a recovery summit. And what we did was we polled individuals regarding this definition. And, really the majority of people identified with the broad definition. And that definition is recovery is a process of change through which individuals improve their health and wellness, live self-directed lives, and strive to reach their full potential. We know that recovery is a process. Pathways are really highly personalized. We build on the strengths and resources of individuals. Their pathways may include clinical treatment, use of medications, peer support, support from families, programs in schools and faith-based organizations, and many, many other approaches. So our current work at SAMHSA is really building upon the work that we have done over the last 10, 15 years and advancing recovery as a cross-cutting principle within our work. So we know that recovery is the positive outcome for people who experience substance use conditions. It really is important to meet people on a level of the knowledge and belief that anybody can recover and or manage their conditions successfully. And that is really crucial to their pathway of wellness. Recovery and recovery-oriented systems of care are widely accepted by states, communities, healthcare providers, peers, families, researchers, and advocates, including many other medical professionals. SAMHSA advanced recovery support systems to promote the partnering with people in recovery and their family members to help guide the behavioral health system and promote health and resilience. And you've heard from many of my colleagues today talk about having people with lived experience within all of that decision-making that's happening across all of these pillars. Recovery support services really help people enter into and navigate systems of care, remove barriers to recovery, stay engaged in the recovery process, and live full lives in communities of their choice. Recovery supports may be provided before, during, after, or in lieu of professional treatment. Recovery support services also provide a full range of services that facilitate recovery and wellness, social support, employment, housing, linkages to and coordination among providers and others that improve the quality of life for individuals seeking recovery. So just as an example, SAMHSA funds many programs that provide peer and recovery support services. I just want to highlight two of those that are funded through our Center for Substance Abuse Treatment. Those are the Building Communities of Recovery grant and our statewide recovery community program grants that both help to expand and develop peer services in the communities in which they are funded. So peer recovery supports provide individuals with connection to someone that has been successful in their own recovery process and can share understanding, respect, mutual empowerment, and help people become and stay engaged in the recovery process, and also reduce the likelihood of recurrence of symptoms. Peer support can effectively extend the reach of treatment beyond the clinical setting into the everyday environment of those seeking a successful, sustained recovery process. And we know that recovery happens in communities. So it's not just that individual, but what happens as they get out of the professional treatment setting. Our peer workforce has individuals that work as a peer with a lived experience to enhance their ability to support others experiencing similar challenges. These individuals that provide peer services provide non-clinical, strength-based support and are experientially credentialed by their own recovery journey, as well as having that certification that they need either through their own state, their local organization, or maybe their own agency in which they work, whatever that requirement may be. Peer support workers help to break down barriers of experience and understanding, as well as the power dynamics that get in the way of working with other members of a treatment team. Peer workers practice in a range of settings, including peer-run organizations, recovery community centers, recovery residences, drug courts, emergency departments, and many others. Peers can also provide outreach and engagement activities in their role. Peer workers complement, not duplicate or replace the role of therapists, case managers, or other members of the treatment team. And I think most importantly, they provide their own experience by modeling recovery and offering hope. Now, Dr. Gandotra did talk about our Peer Center of Excellence, but I also want to highlight that because we have funded the Peer Recovery Center of Excellence, which exists to enhance the field of peer recovery support services. The organization is led by a 6-person steering committee of people with lived experience, and that voice is really the core of the work and their mission. The COE can provide technical assistance and training to support the peer workforce and recovery community organizations. The 4 pillars of the work include the integration of peer support workers in non-traditional care and treatment settings, building and strengthening the capacity of RCOs, enhancing the professionalism of peers through workforce development, and providing research and practice-based resources and information for diverse stakeholders. So with that, thank you so much for allowing me to talk a little bit about recovery support, and I will turn it back to Scott.
Great, thank you so much, Donna. Thanks to everyone that discussed their different pillars. So we have about 25 minutes left right now to really have a discussion about what you've talked about. And again, the idea is to be a town hall. So for those of you who are watching live, you can email your questions to 2022, I did the wrong slide, 2022 nosad@gmail.com. That's 2022 NOSAD@gmail.com. We're happy to entertain your questions. But while we're waiting for that, we're fortunate that I have a lot of questions for you. And some of them will be easy and some of them will be hard. But I do want to touch on all the pillars. To start, I'm actually going to ask Dr. Baldwin. I have 2 adolescent sons, and I'm scared to death right now with what's happening with illicit fentanyl. And of course, we've seen the pills that are fentanyl pressed into pills that look like candy. We've seen just such differences in potency that they're so dangerous. From the lens of primary prevention, how can we address this in this new era of this illicitly manufactured fentanyl, which is just ubiquitous now?
Yeah, because of its ubiquity, we really do need to sort of double down our efforts. And critically important, I think I talked a little bit about our Stop Overdose campaign. We need to raise awareness really across the lifespan, but especially including among youth because of the near doubling of deaths among youth in the last couple of years specifically. But getting even further upstream, we need to attend to ultimately what puts persons at risk for substance use and developing a use disorder, which are adverse childhood experiences. CDC has invested in a major initiative in Martinsburg, West Virginia, which is a community school police partnership. It's both targeted prevention and universal prevention, so trauma-informed care. It's a really innovative program that we're beginning to see pay dividends that I think is a way forward. So if for listeners who don't know, adverse childhood experiences are things such as divorce, experiencing substance use in the home, all forms of violence, etc. We know that persons who experience ACEs and people who experience multiple ACEs are at much greater risk for not just developing a use disorder, but all kinds of other bad outcomes. So if you address the issue of adverse childhood experiences, you get really a significant benefit across a range of outcomes.
And perhaps if I could add, Scott, being kind of the panel that, one of the things that Patrick Kennedy, Mr. Kennedy also mentioned was family history. And really, I think, for all the healthcare professionals out there, beginning to ask that question, we certainly know that there is a genetic component to the development of a substance use disorder or an addiction. And so being able to understand what that history and what that other risk factor, in addition to the ACEs, the average childhood experiences, and other risk factors that Dr. Baldwin mentioned. So I just wanted to highlight that because I think that is something that sometimes gets overlooked, particularly among healthcare providers.
Yeah, it's so important, and also even the idea of what what individuals do with their free time, right? I've heard innovative projects that have happened in Scandinavia where they get kids into after-school programs and really just get them in positive experiences that don't lead them down the path to even want to experiment with drugs.
Yeah, we talk about at CDC safe, stable, nurturing relationships and environments. That's exactly the kind of environment you just spoke about, Scott.
I have a couple questions about data, and this was actually for Dr. Burrell. So I'm a big fan of the public health data warehouse that you put together at your time at the Department of Public Health in Massachusetts. I actually was one of the partners of this program, and we asked a really simple question that hadn't been asked before, or hadn't been answered before, which is patients that I treat in the ER that survive an overdose and we discharge them, how many would be dead within a year? And the number was surprising. It was about 5.5%, which is 1 in 20. And I think of like 1 in 20 of any condition that I'm discharging being dead in a year is staggering. And especially if you consider that the majority of individuals were young and otherwise healthy. So I want to extend my appreciation for that project, but I was wondering if you can talk a little bit more about it, what you learned from it, and how you apply what was learned from it to future initiatives. Yeah.
Thanks so much for your participation in that. And I'm sure there's other people listening who participated in that. And I raise the thank you also because the way that this was structured was as a private-public partnership where individuals, we had the information de-identified, aggregate at the government level, and then needed partners to volunteer who came from across academics and other sectors to help us better understand the data that we were putting together. So that was a really key part of the success of this, and the public health data warehouse is still being used today for opioid use as well as other complex public health issues that need to be understood. So, as you point out, there's some basic information that we didn't have, including, what's the prevalence of opioid use disorder in Massachusetts? It was about double what we thought it was before that. And even though some of this information we have from more national databases, being able to localize it so that individuals can then act on it at a local level was really powerful. We were able to understand who was at greatest risk for opioid use disorder death related to the data. So we've talked, all of the individuals that have spoken have talked about the dangers of opioid use in the imminent deaths and the number of deaths we're seeing. So who's at greatest risk that we have to pay attention to and target our resources? And similar to what was raised earlier, those risk groups included pregnant and postpartum women, individuals with a history of criminal justice involvement, individuals who have experienced homelessness, those with co-occurring illness in our communities of colors. And that allowed us to look at what programs and policies we had in place and how we could really focus in on those highest risk individuals. And specifically in the criminal justice arena, we were able to use the information that we had and take it to our criminal justice partners and talk about how when individuals are released from jail or prison in Massachusetts, at the time we had the data, there's 120 times higher risk of opioid overdose death. And in fact, that happens in the 2 to 4 weeks right after they're released. So we use that to really change the way we think about criminal justice, treatment with medications, and discharge to the community. So that's just a couple of examples.
Yeah, it's phenomenal. And it really can allow you to focus limited resources sometimes as well, too, on the most vulnerable populations, right?
Absolutely.
Yeah. Again, any questions at 2022nosad@gmail.com. And I next have a question for Dr. Olson. You mentioned the Buprenorphine Waiver, which for those that are watching that aren't aware of that, for many, many years to prescribe buprenorphine, in this country, we've needed to obtain a waiver, which initially needed 8 hours of training for physicians, and then subsequently it was added that there could be 24 hours of training for an advanced practice practitioner, like a nurse practitioner or physician assistant, to be able to prescribe. And again, most recently, as of I believe last year, year and a half ago or so, that went away for people treating under 30 patients concurrently, which has been wonderful for people like me that's an emergency physician that I often don't treat that more than 30 patients concurrently. But is it enough, is my question, because I always thought that one of my theories was that the waiver was an excuse for some people that didn't want to prescribe to say, oh, I don't want to do this extra training, I already do enough training. And now that we've removed that barrier, I know you mentioned a lot of people have had the waiver, but are we starting to see positive changes where people are prescribing more, or is this making a dent?
Yeah, no, that's a great question. And thank you also for being one of those people who, is prescribing and treating people and starting buprenorphine in the emergency department. certainly this is, I think, kind of the question on many people's minds, and HHS, and I know Dr. Sherry has been really intimately involved with this. There is an evaluation of the practice guideline ongoing because and one of the different surveys of practitioners who have the waiver, even those who now no longer need the necessary training, but still need to still need to kind of have the intent, the letter of intent sent to SAMHSA and to get the waiver, on the DEA license. What we unfortunately see is that, the vast majority of practitioners are not prescribing to their limit. And, on average, depending on, which category you look at, that some of those categories and some of the percentages are, there's a big gap between kind of the limit and where people are really prescribing to. So, I think the question around whether or not the training, certainly there are we've heard that that it has been perceived as a barrier. I think this is a good test to see, how big a barrier that really is, and what impact it has made. And but also want to really thank all those individuals out there who have taken on this practice and are really able to help people get into recovery and get into treatment, with buprenorphine.
Thank you. And I'd also like to ask Donna, you had mentioned recovery coaches or peer recovery navigators, which I've seen time and again how powerful that role is, how it helps people get into recovery because they see that someone has done it and they see the pathway forward, which for so many people was not even available to them before. But how do we, you mentioned the centers of excellence and the models, but it feels like some of the barrier is really going to be around paying for it, right? The payers, insurers. How do we change that? How do we advocate for that, for there to be adequate reimbursement for us to expand this role to everyone that needs it?
Yeah, so, I think as we get more research and more validity behind the role of recovery support services and recovery coaches, it helps, that will help to validate the work that we're doing as a peer coach. I know that there are several private payers that do pay for that. There are some ways that CMS will pay for it. And of course, a lot of the work that we do at SAMHSA, though not required, it is recommended that we have peer recovery coaches as part of our programs because there is the value of that lived experience. I think, when we think about peer coaches, though, one of the issues, of course, is the living wage, right? And I think it's more across the board, not only just for peer coaches, but the system as well. So, we have folks that are working really hard day in and day out to support people that have substance use disorders. And so meaning medical professionals as well as therapists, counselors, and peer coaches. And so, not just looking at this is what I would think, not just looking at this one peer coach, but really expanding across the board so that we have fair, equitable pay for everyone. And so, just being able to continue with the research and be able to validate the work that peer coaches do. And of course, I think one of the things that we also really need to think about is, peer coaches have a specific role in the work that we do within maybe non-traditional settings. And so staying true to that role and making sure that people are providing that non-clinical, non-professional type service, not as a case manager, but as a not as a therapist, but as that person with a lived experience that works with somebody one-on-one to help them, on their road to recovery.
Great, thank you. Thank you. I just wanted to touch for a minute as well on something that I think all of you mentioned, and also Patrick Kennedy mentioned at the beginning as well too, and is about stigma. And you've each covered it a little bit, but I'm just wondering, in the context of the pillars that you presented, if you'd like to just say a few words about how you address stigma, because that really is one of the biggest barriers right now. We recently did a study looking at medical records at our big health system, and we found that about 61% of patients had some sort of stigmatizing language in their medical records. And so we're trying to fight against this, but how do we do that in the context of your different pillars? And maybe you can just take it in order.
Yeah, I think you just need to tackle it head on. That's part of what our Stop Overdose campaign is about. I know there's other efforts ongoing from organizations like Shatterproof. SAMHSA has some work in the area. We're thinking about expanding work with the Ad Council to do exactly this. I mean, I think the sooner and faster we can get people to sort of really understand what use disorder is and get people aware of how to best attend to it, the better off we will all be. And I think because of its ubiquity, I think it's going to be easier over time to destigmatize. All of us know people directly or indirectly who've been impacted by this crisis. And I think that's going to be part of the solution because it's an everybody problem.
I agree. And focusing on individuals with lived experience, people who are willing to be brave and courageous and talk about it, really changes the dialogue. And whether that's at a community level or in a professional healthcare person's office, being able to understand somebody's lived experience, but really listen to it, is profoundly changes how people think about it, because now you're talking about an individual is exposed to these, this group or this sense of, something that you can't control, and therefore it's easier sometimes to just put it in a box. And from a healthcare point of view, I think it's really important that all of us in healthcare professionals think about ways to expose learners to these issues early on, because stigma builds early, or they'll come into it from preconceived notions. And as Scott, as you know, in Massachusetts, we were the first state, and then others have done this too, to really require training for learners on how to address addiction. And that part I think is particularly important. But the other thing about stigma is we see people change, right? Once you're exposed and you work with someone or you have an experience, people do change. So these campaigns and interacting with individuals, I have great hope. And if you think about it, 10 years ago versus where we are now related to stigma, and how people can think of it as something that is relapsing and recurring, requires chronic treatment, and that there are examples of people who have successfully are in recovery. So I think we're heading in the right direction.
Yeah, and I have three thoughts. One is that, we've already kind of talked about language, and I think language matters. And, the words that we use, the words that we want to avoid, the fiscal year 23 congressional justification, which is kind of the justification that forms our budgets at the federal government, actually has a provision and has some language that would remove the word abuse from even SAMHSA and CSAT and some of the federal agencies that both Donna and I work in. That to me is a huge step in the right direction. It may seem very symbolic, but I think as we really kind of look at the language and the terminology, that avoiding those stigmatizing terms can really go a long way. The second thought I have is that just like Dr. Burrell mentioned about education, that absolutely starting kind of early and continuing through the healthcare professionals trajectory. So SAMHSA funds something called the Provider Clinical Support Systems universities that really are grants to healthcare professional and healthcare academic institutions to make sure that we actually can infuse that and then sustain it throughout the healthcare professionals' training trajectory. The third piece I would mention is also that there are some things that are really simple that we can do, not only kind of paying attention to language, but for healthcare professionals. And you mentioned the electronic medical record study that you did, which was so amazing. That really thinking about where do we actually identify, where in our medical record, where in our history and physical examination notes do we identify when people have a substance use disorder? It actually belongs in the past medical history. Medications like methadone and buprenorphine belong in the medication list. They're not social problems. They're not in the part of the social history. So I think that's another kind of just switching our mindset and framing around, what are these conditions? They are health conditions. And so they really belong in that frame. Those things alone could actually, I think, really help to reduce the stigma that we see, particularly among healthcare professionals.
Thank you.
So I would just agree with all the other panelists. I'm not going to repeat what they said, but I do know that one of the things that I think about is a targeted campaign to specific groups around addressing this stigma issue. The other thing I think with SAMHSA I just wanted to mention is we have the new Office of Recovery, which really elevates recovery and shows the ability of people that they can and do recover, as well as work within a federal agency that, really values people with lived experience. So I just wanted to mention that. Thanks.
Great,
And let me also mention just real briefly, CDC just released along with ASAM the Addiction Medicine Toolkit, which very attentively addresses stigma among the provider population and how they can be a real leader in helping to destigmatize substance use disorder. Over.
Great, thank you. And I was particularly, the point you mentioned, Dr. Olson, about the name SAMHSA has abuse in its name, and I was always curious if that was on the table for reframing, just because, again, the words do matter, like you so eloquently stated. Okay, I have a final question, and it's a little bit of a zinger, and I don't want to get anybody in trouble from your federal roles, at least for 3 of you, but it's firmly for actually in Dr. Burrell's camp around harm reduction. But we've seen at least 10 countries have implemented safe consumption facilities where people can go and inject drugs or use drugs. They're monitored, and then they can be stewarded into recovery if they so desire. But otherwise, the idea is just keep them safe and make sure that they don't die. And we've seen that in various fits and spurts around the country. And I think most recently the traction has been in New York City, where a couple of facilities have opened up. Just curious, in light of all your pillars, where you think that's headed, what you predict for our country for having safe consumption facilities, and if it's a good idea, a bad idea, any insights you have. Thought I'd end with an easy one.
I'll start. I mean, I think it's a major step forward, as Dr. Sherry mentioned, that harm reduction is a central pillar over the overdose prevention strategy, which I couldn't have imagined just a few years ago. I think it's at present, although we've seen receptivity to interventions evolve over time, think of syringe service programs as a specific example, perhaps that will be the case with safe injection sites. I think personally, saturation of naloxone and wider availability and use of fentanyl test strips are bridges that are closer to us that I think we can get much more uptake of those 2 specific interventions, life-saving interventions potentially. So my interest is investing there. I think that's likely where you'll see, again, I'm speaking for me as a person, not me as CDC. I think we're going to push for those interventions before we go to pushing for safe injection sites.
Yeah, I will add that I do think that that HHS, all of us who work at the federal level are also very evidence driven, and so looking at evidence-based treatments and interventions, I think is something that this administration is also supportive of. I do think that there are lots of different considerations, across the country, and so really thinking through, where where there are opportunities to also, as Dr. Baldwin mentioned, and where there are gaps in even with the tools that we currently have that we know really are incredibly effective, in communities across the United States. So, I think it's, I don't know that any of us have a crystal ball, but I do think that, certainly seeing what and following what happens in New York with the two overdose prevention centers that now are established there will be of interest.
Great, thank you. Well, I think with that, we can conclude the panel. I just want to sincerely thank you all for this discussion. It's so reassuring to see the response that's happening both at the state and federal level, and just particularly to learn from your collective experience. I feel like we're in good hands, which is wonderful. And I've really enjoyed chatting with you and picking your brains and learning from you too, and I hope the audience has as well. Your commitment is noticed and really appreciated. And particularly just to transition to the next session, I want to thank Donna as well for sharing your story about recovery. It's so important, again. And so I wish you so well, and thank you again for participating in the panel.
Thank you.
Great. And with this, we will transition to our next session, which, as I just mentioned, is going to focus on two people in recovery. This is Val Comerford and Julie Sprinkle. Especially with this disease, with the substance use disorder, breaking down the walls of stigma really takes learning from people who have walked the path and who have made it to recovery, because that's just probably more powerful than anything we can do to help people that are struggling right now. And so this is why we made this section really the core of the town hall. The middle of the session is to have these two individuals speak to us. So I'd like to welcome Julie and Val. Thank you.
Hello, my name is Val, and I am in long-term addiction and mental health recovery. I have not had a drink or a drug in over 37 years, and I have not been psychiatrically hospitalized in over 30 years. I am also a certified peer specialist. My journey began in AA. AA embraced me and helped me to believe in myself, taught me that I was worthy of love and how to love. I followed the examples of others and came to believe that I could live a life free of alcohol. I went to meetings, got a sponsor, and I felt strong in my sobriety. Then, excuse me, things began to change. I had been keeping secrets. I had struggled for my entire life with overwhelming thoughts of hurting myself. I was obsessed with death and had experienced 2 very serious attempts to die from suicide before I had become sober. I was successfully sober, yet I had lost my will to live. I did not want to drink or use drugs, but I could not shake my obsession with thoughts of suicide. Every bridge abutment, large tree, or steep incline was my ticket out. One night at a concert in Mansfield, Massachusetts, I had a terrible breakdown. It was frightening, and I lost all sense of time and space. I felt like my brain had exploded. I was quickly admitted to a psychiatric hospital. I had no idea what had happened to me. It was there that a very kind psychiatrist told me that I had what he called a dual diagnosis. I had no idea what that meant. He explained that I was both an addict and I had a mental illness. I was so proud that I had maintained my sobriety, and now I feared I would lose everything. He assured me that if I received treatment for both my alcoholism and my mental health challenges, I could become well. I then began to take medication, see a psychiatrist, and continue with the counseling that I had started many years earlier. AA had been so effective that I wondered if there might be another 12-step group where I could talk safely about my mental health as well as my addiction. The internet was just beginning to be talked about then, and a Google search was not even a dream. Along with a small group of people from the Massachusetts Clubhouse Coalition with similar issues to mine, we set out to find some answers. We discovered a new 12-step group called Dual Recovery Anonymous. It was started in 1989 in Kansas City by founder Tim Hamilton. We learned that 60 to 70% of people with addiction also struggle with mental health challenges. All 12-step groups have very specific purposes. The purpose of AA is to help the alcoholic. AA helped me to become sober and continues to do so. The purpose of Dual Recovery Anonymous is to help people that struggle with both an addiction and mental health challenges. We then reached out to the founder, Tim Hamilton, and asked him to come to Massachusetts and teach us how to run Dual Recovery Anonymous meetings. He helped us to study the principles, talked about how it started, accepting differences, and of course, the 12 steps. We became his students. He was an amazing man, and very sadly, he died in 2013. He was not only my mentor, but he was my sponsor for 16 years. At that time, we started the very first and longest running DRA group in the Northeast. It is called It's About Time. We just celebrated our 28th anniversary together. In DRA, I am open to talk about my fears, medication, depression, suicidal thinking, drugs, alcohol, and anxiety. I'm truly free to be me. No more secrets. I believe that there are multiple pathways to recover. Support for harm reduction has become important for so many people in recovery. I embrace them all. Human life is what matters to me. AA helped me to become sober, and DRA, Dual Recovery Anonymous, has helped me to become well. For all pathways, I am deeply grateful. Thank you. Off to you, Julie.
Thank you, Val. Hello, my name is Julie, and I am in dual recovery. That is to say, I am in recovery from both an addiction and a mental health challenge. When I was just a small child, I started hiding food. I struggled with one of the most basic necessities in life, and today I know that I was born with a food addiction. My family tried to help me in every way they could, but unfortunately, food addiction and obesity were a problem for many of them as well. I think the food addiction that created so much pain in me gave me empathy for others. People would often open up to me and share their life's problems and struggles. I liked being a support to others and feeling as though I could help and wasn't just this broken person. For that reason, I went into the field of psychology, and by the time I was 30 years old, I was a licensed clinical psychologist in Massachusetts. I worked with children, families, and adults. I specialized in anxiety and was trained in exposure with response prevention. I had a successful practice, though I continued to struggle with obesity. I had my son at the age of 33, and after he was born, noticed that I started having postpartum symptoms. I was feeling paranoid and out of touch with reality. Being in the healthcare field, I appreciated the importance of psychotherapy and met with a therapist regularly. It seemed to be under control, so I continued my daily life and went back to work after a very short maternity leave. Just a month after my 35th birthday, I had my first full-blown psychotic episode that included delusions, hallucinations, voices, and a suicide attempt. I became completely lost. How could this be happening to me? Hadn't I done all the right things? My friends and colleagues helped me to close my practice down immediately so I could focus on my own recovery and make sure that my clients were well taken care of. My family helped me with my son, and ultimately, my husband and I needed to move in with them. I was in and out of the hospital 8 times in 2 years. I was experiencing a level of instability that I didn't think was possible for me. My takeaway from this experience is that mental illness is real. It is not something you make up in your head. It is not because you're a bad person or irresponsible. At least in my case, it was my genes expressing themselves. Bipolar disorder runs in my family, and unfortunately, though I thought I was in the clear, I started to experience a level of psychiatric pain that felt insurmountable. Not knowing what to do with my day became a major issue. I couldn't care for my son because I was too ill, and I couldn't go back to work for the same reason. This need for structure and purpose in my life led me to Crossroads Clubhouse in Hopedale, Massachusetts. Crossroads was an employment rehabilitation program for people with mental health challenges. I didn't know if I would ever be able to work again, given the severity of my symptoms, but I did know that I couldn't just sit at home in pain and suffering. When I got to Crossroads, I was welcomed with open arms and was invited to attend the Dual Recovery Anonymous meetings. I said, do I really fit in? I had been attending 12-step meetings with Overeaters Anonymous for food addiction, but would I be considered someone who was in dual recovery? Isn't that just for drugs and alcohol? No, DRA is for people in recovery from any addiction and any mental health challenge. There were people there recovering from smoking, gambling, food, shopping, sex, you name it. It's an opportunity to work on your recovery through the 12-step model, and I can honestly say 8 years later, it has saved my life. I learned through DRA that I can't improve my health without treating both my bipolar disorder and my food addiction at the same time. At DRA, I can talk about all of my recovery needs with peers who can relate and understand. I can talk about my whole self, challenges and successes, assets and liabilities. After just a short time at the clubhouse, my hero, Val, who you just heard, handed me a job opportunity. Can someone work who is actively psychotic? Yes, you can. I got a part-time job with the Massachusetts Clubhouse Coalition, supporting and organizing events for DRA across the state. The virtual meetings on our website are open to all, and I encourage you to join. If you are struggling with any addiction and any mental health challenge, you are welcome. Providers, supporters, you are all welcome. Please go to our website to learn more. That's massclubs.org. massclubs.org. Thank you.
Great. Thank you so much, Val and Julie, for sharing those stories, and particularly just for acknowledging other addictions as well, other use disorders, which are very similar to what we talked about with opioids or other substance use disorders. So sharing your stories, your successes will be a model for people that are watching, and particularly the resources that are available. So on behalf of everybody, I just want to thank you again. And with that, we're lucky to have a lot of partners putting this day together, but one of them is the Kennedy Forum, and you heard from Patrick Kennedy earlier today. And we're just going to take about 5 minutes to share a brief video that was produced by the Kennedy Forum. Enjoy. Gloria, we're not hearing the volume, audio.
parts of a person's treatment and recovery, and friends and family are often involved. Here are some of the best ways to support someone in recovery. Understand.
Looks like we're having some technical difficulty with the video, so perhaps we can move on to our next speaker. Great, thank you, and sorry about that. We'll make sure that we have appropriate links for those videos on the YouTube channel. So now I'm delighted to introduce the next speaker, who is going to begin the part talking about medication for opioid use disorder. Particularly, we have two sections on buprenorphine and methadone. And our first speaker is Dr. Claudia Rodriguez. She's one of my dear colleagues. She's an addiction psychiatrist at Brigham Young Women's Hospital and Brigham Young Women's Faulkner Hospital. She focuses on addiction-related consult liaison work and is the director of our outpatient addiction recovery program. She's an amazing colleague, teacher, mentor, but above all, she's an advocate for her patients. She'll be discussing opioid use disorder treatment with buprenorphine. Welcome, Dr. Rodriguez.
Thank you, Scott, and thank you everyone for being here. I'm so delighted and honored to be a part of today's talk and also to be a part of today and this entire month. As Scott mentioned, my name is Claudia Rodriguez. I'm an addiction psychiatrist, and I am very fortunate. I work in the ambulatory setting where I get to experience stories like the two that we just heard before myself, and hearing stories of recovery. I'm able to see patients really transform their lives into something that they oftentimes don't even think is possible. And that includes like our two speakers talked about targeting the substance use disorder or the addiction, but it also involves tackling mental health things that come along with it, and also just processing a lot of the feelings that come up and the trauma that people experience, even when actively using or in early childhood. As someone said, adverse childhood experiences are a big part of what predisposes us and gives us a higher risk of developing a substance use disorder. So in the next couple of minutes, I really want to spend time with you all just talking about buprenorphine treatment. Buprenorphine treatment is one of the, I'm just going to share my screen. Buprenorphine treatment is one of the 3 FDA approved medications. Let me just fix this. Sorry, one second. It's one of the 3 FDA approved medications that we have for the treatment of opioid use disorder. The other 2 are methadone, which Jan Kaufman is going to speak about next, and also naltrexone, or extended release naltrexone, which is the 3rd. So my talk is really about buprenorphine. Now, what is buprenorphine and how does it work? So some of you in the audience may know buprenorphine by its clinical term. Others may know buprenorphine as more commonly referred to as Suboxone or Subutex. This is a medication that comes in several formulations, but most of the patients who are prescribed it take it by putting it under their tongue. It's a tablet or a film. And then there's a somewhat newer formulation that's come out that's a monthly injectable formulation called Sublocade. For simplicity's sake, I'm just going to refer to it as buprenorphine, but I wanted to throw some of those names out there in case they ring a bell to you all. So what are 3 important aspects of buprenorphine? It's a really intelligent medication, actually, and I'm going to use my hands to describe it because I always find that to be the easiest way. So there's 3 important aspects about buprenorphine treatment that I want y'all to know. 1, it's a partial opioid agonist, and I'm going to talk about what that means in a second. 2, it has a slow dissociation from our opioid receptor. And 3, it has a high affinity for that opioid receptor. So I'm going to stop my share for a second so that y'all can just see me. And I'm going to talk about what that means. So what is a partial opioid agonist and what does that mean? So typically we have, let's say, our mu opioid receptors. And so this hand is her mu opioid receptor. And we're going to think about opioids. We have endogenous opioids that are endorphins that bind to that opioid receptor and it creates some type of activity. So typically we think of euphoria, feeling good. Our medications that are opioids, so such as oxycodone, Dilaudid, morphine, those medications that you would get if you have a really horrible tooth extraction or if you have a procedure that requires opioid prescriptions. Those medications come in, bind to the same receptors. We're going to call them our mu opioid receptors, even though there are many. and it's going to activate it. It allows for pain relief and so on and so forth. And then, of course, we have our more illicit opioids, and that includes things like fentanyl and heroin that we hear people struggle with as well. But they all bind to that same receptor, activate it fully. So that's what we call our full opioid agonist. And what does that mean? That means that the more that I take, the more receptors get activated. And as more and more receptors get activated, 100%, so highest amount of activity, that can lead to an overdose, respiratory depression, and unfortunately death. You know, I don't need to tell y'all about the overdoses that are happening in the fentanyl era, but that's definitely part of it is the interaction with the receptors. Buprenorphine is different. It comes in, it has this like really sticky bind to the receptor, and it only activates it 50%. And so that matters for a couple of reasons. So one, you know, when we think of addiction and when we think of how vulnerable our brains are left after using substances on a regular basis, there's many neurochemical changes that happen. And what we really want is we want to give the brain a floor to stand on, right? A foundation for it to start recovering. So what buprenorphine does by binding to that receptor and activating it 50%, but not 100%, the level that the others do, is it gives us that ability to manage cravings, to decrease withdrawal, to not feel like you're stuck in this cycle of addiction that I'm going to talk about in a second. So again, the 50% activation is really great in that way. People feel rescued by the medication. They don't feel sick. They don't feel uncomfortable. And in addition, even if I took all the buprenorphine that I could get my hands on and I activated all of my receptors, there's a ceiling effect. I can only activate them so much. So 50% total activation, meaning the risk of overdose is significantly less. You know, it's just a much safer medication. So when you think about why people say it's safe, that is the reason. There's a much, much significantly lower risk because even if I activate all my receptors, I'm only activating a 50% total, for example. The second thing I mentioned, that it has a slow dissociation. So it sits on that receptor and it slowly falls off. And why is that important? Well, if we think about someone that's struggling with a substance use disorder, they're stuck in this cycle of waking up, maybe not feeling so good, taking the drug or alcohol, and then start to feel withdrawal again, not so great, negative affect. And then we go into thinking about how am I going to get my next dose? And then they're constantly in this cycle where they're stuck and unable to really fulfill their life goals or what they want to do. And so what happens with a medication like buprenorphine, where it slowly dissociates from the receptor, it lasts a pretty long time in someone's body. What that means is that it can be dosed once a day. So much like methadone, we can dose it once a day. The nice thing about buprenorphine is it can be prescribed by someone like me in the outpatient ambulatory world, by someone like Scott in the emergency department. You get a prescription, you fill it at a regular pharmacy, and you take it every day. The doses vary from 8 to 24. There's a few patients that may be on more than 24 milligrams of buprenorphine a day. But the idea is they dose it once a day, done, or you can dose it more, but generally people can take it once a day and be okay as far as cravings, withdrawals, substance use, etc. goes. And then the final thing I mentioned, it has a high binding affinity at that receptor. And what does that mean? So in less clinical terms, what it means is that my receptors are gonna hold on to buprenorphine tighter, and they're going to prefer it over other opioids. So that has two important, that means two important things. One thing is clinically, before you can start buprenorphine treatment, you want to make sure that the person's receptors are not occupied only by full agonist medications or drugs. So what does that mean? If someone is taking oxycodone every day, and I give them buprenorphine, it kicks it off, and then that person's going to go from a high level of receptor activation to somewhere in the middle. And that's going to feel uncomfortable. That's what we call precipitated withdrawal. Now, there's newer ways that we're approaching this in the era of fentanyl. Things have gotten a bit complex. Fentanyl analogs can be very different. They can last for different times in someone's body and their system, and they can have various impact on how they can start buprenorphine treatment. So in the medical community, we're getting creative. How can we help patients without having to have them wait until they're withdrawing and still start this life-saving treatment? And then the other thing that matters about this is when a person is in recovery and they're taking their medication every day. Again, because your receptor prefers buprenorphine over anything else. If there's oxycodone, if there's fentanyl, if they have a day when they are really vulnerable, they have trauma memories or something happens in their life, divorce, a death, a loss of someone, something happens where unfortunately substance use happens. If they use an opioid, buprenorphine is still holding on to that receptor. So fentanyl may break through, but it's going to still be protective with regards to overdoses, and it's still going to protect people from feeling the high extent of euphoria or disconnection that they may be looking for at that moment. So those are three important facts about buprenorphine. Again, partial opioid agonist, slow dissociation from the receptor, and high affinity from your opioid receptor. For your opioid receptor. So again, what we want to do is we want to give the brain a foundation to heal while the rest of the person does. And what I mean by that is keep in mind that when people are starting to engage in recovery, there's lots that comes along with that. So there's shame, there's guilt, there's depression, there's mental health diagnoses that may kind of come to light when someone's working on their recovery. So buprenorphine is really giving us this ability to give the brain this foundation. And in general, with ongoing substance use, unfortunately, we're left with a brain that's conditioned to respond to stimuli in the environment associated with substance use. So triggers, right? We know that people's brains, when they have had a substance use disorder, respond differently than someone that hasn't. So for example, if I have struggled with alcohol use disorder and I walk by the bar where I frequently drink, you can see my dopamine. If you could look into my brain, areas of dopamine in my reward system start to fire, even if I am not actually drinking. That's a very different response than someone that does not have an alcohol use disorder. So we know that there are these neurobiological differences that happen. There's also a brain that prefers drug rewards over non-drug rewards. And this explains why sometimes when people are actively using and they're struggling with a substance use disorder, it's harder to think of food as a reward. It's harder to think of connection, companionship, these things that, we often see fall down in a priority when someone is struggling with substance use. Decreased sensitivity to all rewards. So whereas I may enjoy, a sushi roll, someone with a substance use disorder may not have that same capacity to enjoy that because of the impacts on their reward system. Heightened stress reactivity, and then lessened capacity to perform executive processes. And this can also include distinguishing between immediate and delayed rewards. So this is all at the area of your brain. And that's why we really want to tackle and normalize some of what's going on in recovery. I really appreciate saying this to patients when they're just starting in their recovery journey, because sometimes people feel guilty that they're thinking of using. But your brain has made these very strong connections, and your reward system and stress system has been altered in a way that it will recover, but it will take time. And so this is why medications matter. Now, inpatient management or withdrawal, or what we typically hear of as detox, is simply not enough. And this is just one study that was of 40 patients, and they were randomized to either daily dosing with buprenorphine, that's the line at the top, up to 16 milligrams. And then the line that kind of falls down pretty quickly is the control group, which are individuals that were started on buprenorphine, but buprenorphine was used to basically help them undergo withdrawal management. What we see here is a pretty significant difference in the patients that remained on buprenorphine treatment, 75% treatment retention. Everyone here received therapy. They received urine toxicology screens, and the patients who were on buprenorphine, toxicology screens were 75% negative for opioids and other substances of use. And so we really see a significant difference. And in fact, in the control group, 4 patients actually died. And so the whole point of this, and many studies have shown this, is that it's actually really important for treatment to continue outside of those 3-4 days when you're just helping the body kind of, come to the ground again. Here's another slide that shows, this was a study done in France. France expanded access to buprenorphine, and they had no required physician training. Earlier we talked about how to prescribe buprenorphine now, some of the requirements have been decreased from an 8-hour waiver to being able to simply fill out a notice of intent form. But in France, by 2005, there were about 90,000 patients treated with buprenorphine, about 10,000 with methadone. And what they found was that there was a 5-fold reduction in heroin overdose deaths, 6-fold reduction in active injection drug use, 3-fold reduction in the number of babies born prematurely to mommies with an opioid use disorder. And in fact, HIV prevalence amongst patients who used via injection decreased from 40 to 20%. So 3,500 lives were saved with this intervention. And so what is that to tell you? This is one of many studies that shows us that treatment definitely works. There's a reduction in mortality, all-cause mortality, so anything related to opioid use and overdose, reduction in morbidity, and improved treatment retention. Now, you know, we talked earlier that there's definitely biases in the way that we approach treatment. And what I always think about with biases is, as much as there's stigma towards substance use disorders, we live in a world where unfortunately drug use has been heavily criminalized, and it's impacted people of color and how society views drug use in one community versus another. If you notice that about yourself, that's okay. You know, I think that we develop these biases and the stigma because of messages that we've heard along the way through our parents, through where we live, through our communities. So what I would like to do is to challenge those. Buprenorphine absolutely works. I explained some of the pieces of how it works and why it works, how it saves lives. But here are 2 studies that I wanted to share with y'all. This study was a study that looked at 2 surveys, the National Ambulatory Medical Care Survey and the National Hospital Ambulatory Medical Care Survey between 2004 and 2015. And though we did see an increase in the prescribing across all, there was actually white patients were 0.77 times more likely to receive buprenorphine treatment in a prescriber visit than their Black counterparts. And as you can see, also when you look at the visits based on financial resources, so what it found was that those with more financial resources were 12 times more likely to be prescribed buprenorphine compared to those with private insurances. And if you look a little bit more, what we see here is, again, another study that actually, this is from New York City, and it defines social areas based on poverty level, Black, non-Hispanic, Hispanic demographics in the social area. And if you look at the graph on the left, what you see here is that the social areas that were financially less stable and also that were primarily Black, non-Hispanic, were less likely to have buprenorphine treatment. So buprenorphine treatment, again, increased in all social areas over time, but there was a significantly higher rate of increase in the social areas with highest income and lowest percentage of Black, Latino, and low-income residents. And so, again, biases are there to challenge them. I welcome you to bias and to challenge any bias you have about buprenorphine treatment. I think in our communities, with some of this information that you gathered here today, spread the word that recovery is all around us and that it's not as obvious to see as someone who's acutely intoxicated. Someone on buprenorphine, you wouldn't be able to tell they're on buprenorphine treatment. They look like you or me. There's absolutely nothing different about it. And we are very fortunate to have this medication. It certainly has helped people recover. And so with that, I am so grateful to you, grateful for your attention. And I will stop sharing my slides and let the next person go. Thank you so much.
Great, thank you. Do we actually have time for a question? Is that okay?
Oh yeah, absolutely. Right,
Okay.
I forgot.
First of all, for everyone watching online, feel free to write an email to the address above, 2022nosad@gmail.com. You can ask questions of the speakers that are in this section. But I just had a really quick question for Dr. Rodriguez. And you alluded to it a little bit, but I know some people are starting to use really small doses of Suboxone, and particularly for people that have tried it and then they felt they were allergic to it or they didn't react to it well. I heard that this might be a way that they might be able to try it. And I was just wondering if you can say a few words about that.
Absolutely. So if in the audience, we have clinical members and we have members of the community, it's really important to recognize that, as I mentioned, it's a low dose buprenorphine initiation protocol that many clinicians are using nowadays. And part of the reason why this was created and thought upon is because many patients were noticing that in the era of fentanyl, where fentanyl can live in your fat cells for a long time, there's different analogs with unclear metabolism and just a very unstable molecule. They were noticing that even after waiting some time to start buprenorphine treatment, again, because of that partial agonism and receptor preferring buprenorphine, they still struggled and they were still going into withdrawal, and that was a very uncomfortable experience. And so people felt like either they were allergic, they couldn't tolerate it. And so what we're doing now is we're starting low doses of buprenorphine. So you slowly start to occupy some of those receptors with the partial agonist while allowing that other molecule, be it fentanyl, to still be there and kind of slowly take over and almost, one takes over the other over time without having to experience that level of discomfort. And so it's a different way to approach this. There's other ideas out there, but we are certainly not in the place where if someone has had precipitated withdrawal from starting buprenorphine, it's not worth trying again. That would be information you would want to bring to your provider so that they're well aware, and then they can try to implement a different way of starting the medication.
Fantastic. Thank you so much, Dr. Rodriguez. Wonderful talk.
Thank you.
And now we're going to shift gears to a second pillar of medication for opioid use disorder treatment, which is use of methadone. And for this, I have the pleasure of introducing Ms. Jan Kaufman. Jan is Vice President of Addiction Treatment Services for North Charles Foundation, the Director of the Addictions Consultation Service at Cambridge Health Alliance, and an Assistant Professor of Psychiatry at Harvard Medical School. Jan brings a wealth of experience treating addictive disorders for nearly 40 years. She'll be discussing treatment of opioid use disorder with methadone. Welcome, Ms. Kaufman.
Thank you so much. It's a pleasure to be part of this wonderful day. I'm just going to share my slides, hopefully successfully. Let me just make sure, there you go. So what I want to talk about today is methadone treatment. And what's important about this is, like buprenorphine treatment, it saves lives. And this is a medication that we've had a lot of experience with over many, many years. So what I want to do is present a number of aspects. I'm going to talk a little bit about the history and efficacy of methadone treatment, some of the early research. I would like to talk a little bit about who's appropriate, how the medication works, the kind of services that are offered in an opiate treatment program, which is what an OTP is, and some of the stigma that continues for patients on methadone treatment. Unfortunately, it's not just stigma for people of color, but it's stigma for the medication, which continues, unfortunately, despite what we know about it and how well it works. And then I want to talk a little bit about the impact of COVID-19. So let me start by telling you a little bit about the history. So doctors Vincent Dole and Maria Neiswander. Maria Neiswander was a psychiatrist, and Dr. Dole, a research endocrinologist. And they learned that methadone as a medication, which had been available for pain management since 1947, really had some special properties that worked for people with opiate use disorder. They discovered that it relieved drug craving and hunger. It was medically safe if used carefully. Patients functioned normally, without anxiety and associated drug cravings, and that methadone created a blockade. So patients who were on adequate doses did not experience euphoria or the tranquilizing effect of other outside opiates. And they could stay on their dose for long, long periods of time without creating tolerance. The goals for methadone treatment are not unlike other substance use disorders, but I think some people misunderstand that, thinking that we're substituting one drug for another. But similar to buprenorphine, the goals for treatment are It prevents or reduces drug craving. It prevents and reduces any kind of withdrawal symptoms from opiates. It's helpful in terms of relapse to any kind of addictive drugs, or addicted opioids, so that if taken on a regular basis, it can prevent relapse, and it allows patients to restore some semblance of normalcy in their life. So if the medication is on those receptor sites and on those receptor sites on a daily basis, as Dr. Rodriguez talked a little bit about with buprenorphine, although it is a full mu agonist as opposed to a partial agonist, it will really help people stabilize so they can go about their lives. So the goals really are rehabilitation and abstinence from illicit drugs. So in methadone treatment programs, or OTPs, we work on all kinds of illicit drugs, but the primary focus of our treatment is for those who have opiate use disorder. The medication methadone replaces short-acting, illegal, adulterated, expensive, injectable drugs with a longer-acting agent that you can take orally. It's legal, it's quality controlled, and it works beautifully. I put this here to sort of say that with this medication, you want to start low and go slow. One of the things that I think patients experience a little bit of frustration with when they enter into opiate treatment is that it does take a while for us to get them to a stable dose. And the reason we go very carefully with this, we want to give enough to eliminate withdrawal, but not enough to create intoxication. And also, if we go too quickly, it has risk of people being could become overdosed from the medication. So it needs to be medically monitored and handled correctly. And then, the risks, for adequate doses are very well managed. This medication lasts for 24 to 36 hours with once-a-day dosing. Most patients will get it every day, but there are some patients who feel some effects and can last for a little longer than 24 hours. With an adequate dose, it can create a blockade to other opioid medication. For best results, though, psychosocial treatment is part of it. So although we spend time focusing on the medication, what we need to understand is the treatment of an opiate use disorder is not just about medication, but it is about the treatment of the disorder. And many of our patients have co-occurring psychiatric disorders that need to be stabilized and treated as well to have positive outcomes. So the efficacy of methadone treatment has been studied for a long period of time. And with these studies, you'll see that it reduces death rates, it reduces IV drug use, it reduces crime or eliminates crime days. It reduces the rate of seroconversion to HIV and other kinds of infections. It reduces the relapse back to IV drug use, and it helps people gain employment, health, and social functioning, and to stay in treatment. So medications help patients stay in treatment by stabilizing those receptor sites. And the studies have shown that medication treatment for opiate use disorder, is better than or more successful outcomes than medication-free alternatives. So who's eligible? So you have to be dependent on an opioid drug. You need to be, according to regulation now, you have to show that if you've had an opiate use disorder for the better part of 12 months. And if that's not the case, then you would be able to get a 180-day detox. So we're hoping that some of these things will be a little bit more to the physician's discretion to decide who might be eligible and who isn't, particularly in the days of fentanyl, where it's so risky on the street. We want to engage patients as quickly as possible and make those decisions based on clinical judgment, not on, a period of time or months. There are exceptions to these timeframes. That is a patient who has been released from a correctional institution within a 6-month period, someone who's pregnant who was a priority to engage immediately in treatment, and somebody who had been treated with opioid treatment within a 2-year period of being discharged from prior treatment. It is also available for patients under 18 years old, but you have to have parental consent and 2 documented unsuccessful attempts at tapering off a medication prior to that. So this is how methadone works. So if we think about somebody who uses opioids, initially they're going to get high. So what I'm talking about is people who are using them on the street. So the initial introduction is a high state. Then after a period of time, you will begin to see this drop gradually over a 24-hour period. So what you see is people very quickly go from being high to not being in withdrawal, but in what is sort of an artificial comfort zone where they are not intoxicated, yet they're not in withdrawal. So they're in this period of time until they drop below that. And so for some patient, it varies. 5 to 6 hours, some a little earlier, some a little bit more, and they begin to feel what we call sick. And those symptoms would be initially subjective symptoms. So these are symptoms that you can't necessarily see. There are symptoms that people report in terms of how they feel, which is extremely uncomfortable, anxious, drug seeking, craving, and then they will start to develop some objective withdrawal signs, ones that we can actually visibly see and evaluate. If we use methadone, what you'll find is with this pink bar, it keeps the patient in this comfort zone. So they are not getting intoxicated from the medication and they're not dropping into withdrawal. So for a 24-hour period, they basically are straight. And with that, it allows us to engage in meaningful treatment, which is individualized for each patient, to allow them to work on their recovery goals. Opiate treatment programs have a core number of services. We do initial psychosocial assessments. They get a physical exam and blood work prior to admission. They have pregnancy testing because we want to make sure that we know whether a patient is pregnant or not, and that informs us in terms of how we titrate doses, daily medications, and there are take-home options, which I'll say a few words about in a minute. We do routine toxicology screening, typically urine screening, but often saliva is used, particularly for patients who have difficulty producing a urine sample on demand. And there are patients who, for example, have had histories of trauma, or have medical conditions that don't allow them to be able to produce on demand. We check the prescription monitoring program, which in Massachusetts is called MassPat, and we do that as we admit somebody into treatment. So prior to starting their dose, so we know what medications they are prescribed, what scheduled medications they're prescribed, and then we do that annually. Around the annual review, and then we do it for cause. So if there's some concern and we want to see whether a patient is getting prescriptions elsewhere, it's a way that we can find that out. We also have tests which we call peak and tro, and these tests are basically if a patient is having difficulty with their metabolism, it allows us to see if they're a fast or slow metabolizer, and that allows us to adjust dosing and dosing schedules for some patients. For some patients, we may split the dose with documentation of a peak and trough. That happens often for patients who are pregnant, particularly with dose adjustment needs in the 3rd trimester of pregnancy. And counseling services are required. That's part of our treatment. Again, it's individualized. It's not a one-size-fits-all, but it addresses individual, group, and family treatment. I think one of the challenges we've had with COVID is not being able to provide the group treatment like we had in the past, and that's something that we hope we can continue going forward. Other kinds of services is assessment and management for co-occurring disorders, including psychopharmacology, so psychiatric disorders and so forth, a lot of case management and case coordination. I mean, OTPs are often the entry point into healthcare. And so we discovered that patients haven't seen a dentist in 10 years. They haven't had a healthcare exam provider or a physical exam. They may need OBGYN care or psychiatric care. So we can often be the entry point into healthcare for that patient and then help coordinate that care going forward. We also do tobacco, HIV, HCV testing and education, and provide access to referrals and treatment when needed. So one of the most important things I want to say, and again, this begins to address this whole issue of stigma, is addiction is a condition or a disease that you have. It is not who you are. And I hear patients refer themselves as an addict or in more pejorative terms. And I want to really help people understand this is a medical condition and something you have. It's not who you are as a person. So who are our patients? I mean, we see patients with all kinds of substance use disorders, alcohol use disorders, primarily in an OTP. They enter into treatment because opiate treatment is the primary disorder we're treating, but we also treat and look at all the other substance use disorders. So it's not uncommon for cocaine, nowadays for methamphetamine, benzodiazepine problems, and chronic cannabinol problems for many of our patients. There are different patients. Some people have never used a needle in their lives. Other patients were prescribed opiates for treatment of a medical condition that sort of triggered an addictive disorder for them. Some people have co-occurring psychiatric disorders, which some of our patients with learned experience have talked about. Some have serious medical conditions or problems and infections. So those are the folks who we see. We have patients with COVID. I mean, we have all had patients with COVID these days. Buprenorphine may not have worked for them. And so some people come into methadone treatment because buprenorphine may not be adequate to help them, sustain recovery. Some of them are younger, some are returning veterans, some have been in accidents, some are patients with disabilities, with chronic pain, and some are older with chronic medical conditions. And our patients are also drug and alcohol free on take-home medications. They may be bagging your groceries, they may be professionals, they may be caring for children and elders and working in mental health and addiction treatment programs. But unfortunately, stigma still holds, not only for opiate use disorder, but particularly for methadone treatment. And so they often can be isolated from mainstream medicine, and they don't necessarily able to access good care, or they're not taken seriously. They're stereotyped, they're misunderstood. People still say you're just substituting one drug for another, which is really frustrating for those of us who know about the disorder, know how to treat it successfully. They can be isolated from self-help groups sometimes when they don't understand the nature of the medication and how it's work. But we're starting to see that less and less these days, which is wonderful. And I applaud our lived experience recovering folks who really have embraced medication-assisted treatment. Some of them lose jobs or their licenses are restricted. So stigma is still there and language is still there. Unfortunately, we hear things and we read things in the paper, things like somebody being dirty or clean as opposed to drug or alcohol free. They're addicts, or methanone's liquid handcuffs, or we hear things talk about sections of the city like with language like methadone mile. All of this is so stigmatizing and not really respectful of the nature of an opiate use disorder. So I just want to close with a few things that we've learned from COVID to keep track of time. So this has been quite an education for all of us, and a lot has been learned. So we've learned, because people come in on a regular basis, patients are often curbside doses. So nurses are administering the medication and giving take-homes for people who report symptoms of COVID, or patients with disabilities who are unable to come in. Sometimes significant others will give take-home medication to them so that they're able to safely administer or help the patient administer their medication. We've staggered dosing schedules. We're helping maintain social distance. And now the availability of mobile vans allows methadone to be delivered from an OTP to areas or rural areas where access may not be the same. Expansion of take-home dosing eligibility. So folks who are eligible for take-home medication, of course, we want to make sure that everybody is safe, both from a health point of view, medication point of view, and safety in the home. We want to make sure that the patient is stable, looking at their current take-home status, are they using any other illicit substances, or is their pattern of use at risk? They have to be able to safely storage the medication. So we review all of this stuff with the patient. They have locked containers to take those medications. For somebody who might have a disability or at high medical risk, those are things that are considered for take-home medications. People who are working or child or elder care have transportation issues. These are all things that we consider around take-home medication. The only folks who are really not eligible for take-home medication are brand new admissions until they are stabilized on their doses, who are currently or continuing to use opiate or really increased risk of use. People who are on a dose that's just not stable yet. People who have co-occurring psychiatric disorders that need to be stabilized in order for them to safely take the medication, or people who may be living in unsafe living situations. So somebody who may be in a domestic violent relationship and it's not safe for them to have the medication in their home. And we've learned a lot of things. There've been a lot of challenges with COVID-19. One of the hardest things is really requiring people to come in for in-person physical exams. A lot of our patients don't have technology or internet access, which makes it really hard to do group treatment. But we do a lot of stuff by audio only, which is really helpful for many of our patients. Really ensuring that patients are not at risk and that inductions may be done that are challenging at the curbside, but we can still do it. And I think that's important to know. Some of the benefits are that we've learned is that, the lines are smaller, we can help social distance, we can actually, it becomes an incentive for people to get more take-homes if we're able to give them earlier on in treatment. And patients have had increased attendance to counseling and much more flexibility, both for the clinician and for the patient, and a lot of positive feedback. So we're hoping that some of the regulations will learn from what we've learned from COVID experience and allow for us to make some more clinically informed decisions that are not based on regulation necessarily, but maintaining the safe components that the regulations provide. So thank you very much for the time for this presentation. I hope it's helpful, and it's been a pleasure to be part of this panel.
Great, thank you so much, Jan. It was a wonderful talk, wonderful primer about methadone. And if you're out there struggling with opioid use disorder, just know that there are approved treatments like buprenorphine and methadone. There's also naltrexone, which we didn't speak about too. They all play an important role in this. And so please, and we're continually learning how to use them as well too, especially in light of the new opioids that are out there, like the more concentrated fentanyl. So please do talk to your addiction provider. We're going to just quickly try again to show you the video from the Kennedy Forum, and then we'll move on to Dr. Wakeman after that. So please go ahead and cue up the video.
He drank for years, and it nearly ruined our marriage. We were on the brink of divorce, and he finally got sober. Those early days were so hard.
I didn't know how to help my daughter when she was in college. She got into trouble at school, and even got suspended. She worked on herself, but I had to make some changes too.
My family was basically done with me. I drove them away for 15 years when I was drinking. When I got sober, I had to ask them for help, and that wasn't easy.
I had to take opioids after my back surgery, but I kept taking them, and I ended up with a huge problem. My husband was frustrated, and I didn't know how to explain it to him.
These are the voices of people recovering from a substance use disorder and the people closest to them. Treating a substance problem and maintaining recovery are challenging for anyone. The journey from initial use to problematic use often changes people's relationships. Acute medical care, short-term abstinence, and maintaining long-term changes are all important parts of a person's treatment and recovery, and friends and family are often involved. Here are some of the best ways to support someone in recovery. Understand substance use. Know about problem use, tolerance, dependence, withdrawal symptoms, and cravings. Each of these has a powerful effect on the person who is struggling with a substance, and each affects how that person thinks, feels, and interacts with others. Be patient. Treatment for substance use disorder does not end when the person stops using. That's usually just the beginning. Starting treatment can be difficult. People are making major physical and behavioral changes. The more patience you can offer, the more they can focus on the challenges of treatment and meaningful change. Honor a person's choice in treatment. There are many ways to stop using a substance, including hospital-based programs, residential facilities, professional counseling, and self-directed and community-focused 12-step peer groups. Friends and family members may not always understand or agree with all treatment options, but a person's own choice for his or her treatment typically gives that person the best odds for long-term success. Be a part of their support network. People with strong support networks experience a greater chance for meaningful change. Friends and family may experience some of the same challenges as the person in treatment, but a strong support network is essential when treatment gets hard. Maintain your boundaries. Be supportive and offer reasonable, practical help. It's also important to remember that your loved one's treatment and recovery is his or her responsibility. It's not possible to recover for someone else. It also doesn't help to punish or reject someone when he or she struggles. Grow your own support network. Just as your loved ones need support because of the challenges experienced in treatment and recovery, friends and family also benefit from support. It can be really helpful for you to connect with other people in your situation to get support during this challenging time. Relationships will change. Treatment and recovery from a substance use disorder will affect almost all aspects of a person's life, including relationships. These changes are often unpredictable and can be challenging, but change is inevitable. Recovery may be a lifelong journey. While some people are able to address a problem with substance use quickly and effectively, and can even return to some form of controlled or moderated use, many find that lifelong abstinence is needed. Supporting another person's treatment and recovery can be a challenging time in any relationship. Substance use is a common problem, and there are many effective treatments available for people who want help. Friends and family members are often affected by someone else's use and decision to seek treatment. Taking the time to learn how to help might be the most important thing you can do for a person you care about.
Great. And with that, we're going to transition to the last of the formal presentations we have for today. It's my honor to introduce Dr. Sarah Wakeman, a person I have the incredible privilege to work with at Mass General Brigham. Dr. Wakeman is the Medical Director for Substance Use Disorder at Mass General Brigham, the Medical Director for the Mass General Hospital Substance Use Disorder Initiative, Program Director of the Mass General Addiction Medicine Fellowship, and an Associate Professor of Medicine at Harvard Medical School. Dr. Wakeman is going to be discussing one of the most pressing issues of the current overdose epidemic, which are the inequities we are seeing in substance use disorder treatment and substance use disorders overall. Welcome, Dr. Wakeman, and we're looking forward to this very important talk.
Thank you so much, Dr. Weiner. Thanks for having me. I'm incredibly excited to be here and to join this incredible group of panelists and speakers, many who are friends and colleagues today, as well as many people with lived experience. I think Gloria was going to share my slides, so I'll wait for the slides to be put up. And I'm delighted today to talk about a deeper dive in inequities in the overdose crisis and substance use disorder treatment. It's been really amazing to see that pretty much every speaker has touched on the fact that there are deep inequities in what we're seeing. And I think that needs to be a part of every conversation. So it's great that we've already covered some of the really deeply upsetting data and the need for urgency in our approaches, as well as some of the strategies that are happening already at the federal level. Next slide. So you heard about this a little from Dr. Sherry and others today, but nationally, although overdose deaths are rising for everyone, racial disparities are worsening. So if we look at just 2020, we saw the highest increases amongst Black individuals and Native people across America when we look at overdose deaths. So in just 1 year, there was a 44% increase in the overdose death rate for Black people and a 39% for American Indian and Alaska Native people. This is intertwined with deep structural inequities and barriers, including income inequality that we know is intertwined with structural racism. And so if you look at, for example, counties that have the highest income inequality, overdose death rates are 2 times higher for Black people living there. Next slide. Here in Massachusetts, our overdose disparities mirror national trends. And you can see, looking here, that we've been very fortunate to have really granular data thanks to the leadership from people like Dr. Burrell, who you already heard from. And this is some of that data that Dr. Weiner was talking about that his research team has looked at. When we look at year-over-year trends, we can see that Black, Latino, and American Indian men and surpass those of white men. And in fact, for Black men alone, there was a 66% increase over 2 years in opioid-related overdose deaths between 2019 and 2021. Next slide. Although it's more recent that we're talking about this, this is not anything new. SAMHSA actually put out a great report in 2020 about this, and many researchers and scientists and leaders and community advocates have been talking about this. The overdose crisis in Black communities driven by illicitly manufactured fentanyl, as with the national crisis, has been going on for many years. And yet much of the public attention has focused on this whitewash narrative of the opioid overdose crisis, really emphasizing the impact on white individuals and white communities and ignoring the impact on Black communities, Latinx communities, and Native American communities. This really mirrors our historical approach to any substance use or past overdose or drug use crises in communities of color, where we've responded with the racist war on drugs, with mass incarceration, with criminalization, instead of this softer, gentler narrative around public health that we're now hearing. Next slide. As you can read in this quote from an article about the soaring overdose death rates in Black communities since the onset of the COVID pandemic, one of the many devastations of this is these are communities that have already been gutted by the war on drugs, where families have been torn apart by the child welfare system, where neighborhoods have been hollowed out by sending Black men to prison instead of to substance use disorder treatment. And these same communities are now being hit hardest by the overdose crisis. This is a pressing civil rights and social justice issue, as pressing and profound as any other. Next slide. And it's important to note that this is not an accident. The system is working as designed. So racism has always influenced our drug policy in this country. If you look back to some of the core laws and regulations that guide much of what you've heard about today, why there are special regulations around who can prescribe life-saving medication for opioid use disorder, for example, it was really anti-Black racism that was preyed on and played on to be able to pass some of those laws. So this is a headline from the New York Times in 1914, when people were trying to get the Harrison Narcotics Act passed, and you can see the intense anti-Black racism that is being leveraged here. We can see this play out in mass incarceration across our country. So despite the fact that Black and white people use drugs at the same rates, drug-related arrests vary dramatically by race and ethnicity. We know that Black, Latinx, and Indigenous people are more likely to be stopped, to be searched, arrested, convicted, and harshly sentenced for drug law violations. Next slide. And it's not just the criminal legal system as we think about sort of jails and prisons, probation and parole, but other carceral systems that are really designed to surveil and systems of social control that have deeply impacted minoritized communities and impoverished communities. If you think about the child welfare system, where some people have estimated that 80% of allegations of neglect or abuse are related to allegations of parental substance use, it's not a coincidence that the overwhelming majority of parents who have been involved in the system are either living in poverty or they're Black, American Indian, or Latinx individuals. The system has really been designed in this notion of thinking about individual deficiencies that children need to be protected from their parents. And often allegations of drug use and sort of the mentality of the war on drugs has become the smokescreen behind which this injustice plays out. You can see here the huge racial disparities in terms of who is being removed from their parents' care. Next slide. These racial disparities that we see with overrepresentation in carceral and punitive systems, so overrepresentation in the criminal legal system and who's being arrested and imprisoned, overrepresentation in the child welfare system in terms of which families are being surveilled and torn apart. And we see the opposite. We see underrepresentation in treatment that we know is life-saving and effective. So you just heard great talks about the life-saving impact of medications for opioid use disorder, with buprenorphine reducing mortality by at least 50%. These are game changer medications. And yet when we look at who has the best access to them at the individual patient level, white patients are most likely to be offered buprenorphine. And indeed, buprenorphine was historically marketed to commercially insured and white people. And Black patients have a lower odds of receiving buprenorphine at a visit. And this is in the room with their provider, a person with opioid use disorder. If you're Black, you're less likely to be treated with buprenorphine. Next slide. And this plays out not just at the individual patient level, but at the population level. You heard Dr. Rodriguez quote an important paper by Dr. Hansen from New York that looked at neighborhood level data. This looks at Medicaid enrollees, looking at county level data, and shows that individuals who live in counties with a low poverty rate and a low percentage of either Black or Latinx residents are more likely to receive life-saving medication treatment. So again, showing how these the impact of racism and structural barriers plays out at the individual level and then at the county or the population level. Next slide. We also see racial disparities in treatment discontinuation. So you've heard a lot today about how opioid use disorder and substance use disorder in general is a good prognosis treatable condition. We have highly effective life-saving treatment. Most people can and should achieve recovery as they define it. And yet we know that often treatment has to be long-term, especially when it comes to medications for opioid use disorder. And so when we think about medications like methadone or buprenorphine, we want people to stay on that treatment for often years, or obviously it depends on the individual, but earlier discontinuation is associated with higher rates of recurrence of use and higher rates of overdose. This study looked at predictors of discontinuation and found that Black patients were more likely to have early discontinuation of their medication treatment. Next slide. So what do we do about all this? I think you can see there are racial inequities baked into everything from our policies, our criminal legal approach, and individual treatment access and clinical outcomes. This was a great report put out by SAMHSA, and wonderful to see so many voices from SAMHSA here today, that was looking at community-informed strategies to address the overdose crisis in Black communities. And these 5 sort of key pillars of suggestions of how do we do this? Well, first we look at a comprehensive holistic approach. So although the neuroscience and biology is important, we know that addiction and racial inequities in substance use disorder care and overdose are much broader than the neuroreceptor level. We're talking about fundamental underinvestment in communities, structural racism, many other social determinants of health. We involve the community, and it's beautiful today to see so many people with lived experience here, and involving the community, developing multi-sectorial and diverse partnerships is key in this. We think about culturally relevant public awareness campaigns. Much of the public awareness campaigns that have been previously put out in years past often were whitewashed and not necessarily culturally relevant. We think about culturally specific engagement strategies, really focusing on connection at the core of this effort. And then lastly, we build a culturally relevant and diverse workforce at all levels, from frontline workers, peer support, recovery coaches, to clinicians, to supervisors and leaders. We need leader level diversity as well. Next slide. And I think as we think about how to target inequities, it's worth pausing for a moment to think about the difference between equality and equity. And some may have seen a different version of this infographic or cartoon. This is a revised version by Paul Kuttner of Cultural Organizing. Another image that you may have seen is where the person is shorter, and so therefore standing on the same box, they're not able to see over the fence. He revised this with the notion that the deficiency is not in the person, for example, not in their height, but it's really in the environment. It's the fact that the inequities are in the leveling of the grass, the depth of the ground, and the hole, not the individual height. And so you can see equality would be giving everyone the same height box to stand on to try to see over this fence. Whereas equity is recognizing that because of structural racism, because of underinvestment in communities and many other barriers, people are starting at different spaces, and therefore they need different investments, different supports, different resources to get to the same level. As we think about our substance use disorder treatment program, as we think about overdose prevention, we have to have this framework of what will it take to get to a place of equity? What are those boxes that we need to build? Next slide. This is a wonderful piece that just came out recently, earlier this year, by two researchers, Dr. Friedman and Dr. Hansen. Dr. Hansen is a researcher who has published a lot around racial disparities in medication access. And they really emphasize the role of economic investment and linkage to the broader racial justice movement, that the mere existence of effective medication treatments has not been enough to undo these deep racial inequities. And indeed, if we want to address these inequalities in overdose and treatment outcomes, we really need to connect to broader racial justice movements and think about how do we invest in communities, how do we fund housing, fund small businesses, think about education, and really fundamentally challenge and undo the criminalization of drug use, which both drives poor outcomes for people who use drugs, but also drives poor outcomes for communities of color, where disproportionate policing and incarceration have driven profound inequities. And so thinking about this linkage and this really deep investment to the broader social fabric and broader community need. Next slide. And so to end, I'd end with this last figure from the same artist or author, which really takes it a step further from equity to thinking about what does justice or liberation look like? And how do we challenge the policies in place that have driven many of these outcomes? How do we end the racist war on drugs? How do we think about different approaches to truly address this as an issue of health, an issue of public health, and a fundamental community underinvestment? So with that, I want to thank you. Thank you for allowing me to join. And I just really appreciate being a part of this amazing event. And I'll pass it back to Dr. Weiner.
Great. Thank you so much, Dr. Wakeman. Amazing talk as always. So important. And I really appreciate the revised image of the equity versus inequality, which is a lot more accurate. So thank you for sharing that. So to wrap up, we'd like to just provide the audience with some resources that are available. And for the first section of that, I'm delighted to introduce Taylor Bryan Turner. And really in this section, we've saved the best for last. Taylor is an assistant regional administrator from Region 1 of SAMHSA. We were fortunate to be introduced to her about a year ago and have been so impressed with her wealth of knowledge, innovative ideas, and above all, spirit of collaboration, which has really made this day possible. She'll be discussing treatment resources, the new 988 hotline, and then the SAMHSA resource locator. So I'll turn it over to you, Taylor.
Thank you so much, Dr. Weiner, and I think Gloria is going to share slides for me as well. Thank you, and distinguished guests, to the vibrant voices from people with lived experience who continue to live their lives out loud. It has been an inspiring afternoon, and we are elated to be part of this important town hall today. So my name is Taylor Bryan Turner, Assistant Regional Administrator, and I'd love to take a moment to share with you just two important resources that can help save a loved one or a neighbor. The first is 988. Next slide, please. Enhancing access to suicide prevention and crisis care is one of the 5 core areas of focus within SAMHSA, and both HHS and the White House have prioritized mental health and substance use as a critical priority for the federal government. On July 16th, HHS and SAMHSA launched the 988 Suicide Prevention and Crisis Lifeline, someone to talk to, someone to respond, and a place to go. Next slide, please. Too many people are experiencing suicidal, mental health, and/or substance use crisis without the proper support and care that they need. And sadly, the pandemic has only intensified this challenge when it comes to mental health and wellness in America. With 988, we're poised for a much faster transformation of our country's crisis care system. And 988 is indeed a message for hope. By the numbers, in 2020 alone, the US had 1 death by suicide about every 11 minutes. And for people aged 10 and 14 and 25 and 34 years old, suicide is the second leading cause of death. Additionally, from April 2020 to 2021, over 100,000 individuals died from drug overdoses. And I am extremely grateful to our partners for raising awareness and providing the screening tools, resources, peer voices, and support today and during this recovery month. Next slide, please. There is hope. The 988 Lifeline works and provides free and confidential support to people in suicidal crisis or mental health related distress 24 hours a day, 7 days a week across the US and territories. And as equity is extremely important and interwoven in everything that we do, 988 is accessible to over 200 languages, about 250 to be exact. And it is safe. No personal demographic data will ever be shared when you contact 988. The Lifeline is a national network of roughly 200 local independent crisis centers equipped to help people via call, text, or chat. And when people call, text, or chat, they will be connected to trained counselors that are part of the existing National Suicide Prevention Lifeline Network. And you can access the chat by visiting 988lifeline.org. If you call the Lifeline, you're given 3 options. You can press 1 for Veteran Crisis Line, 2 to connect with a Spanish sub-network, or remain on the line to be connected to a local crisis center. And since the Lifeline has grown, our speed to answer, chat, call, and text has increased dramatically, as well as our call volume. In July 2020 compared with July 2021, the 988 Lifeline saw a 41% increase in overall call volume, excluding calls to the Veterans Crisis Line. And we are so grateful for the dedication to the Biden-Harris administration, investing upwards of $432 million to scale crisis care capacity, provide special services, including the sub-network for Spanish speakers, to ensure all Americans have access to help, and it's proven to work. Data shows that after speaking with a trained counselor, most callers feel less depressed, less suicidal, less overwhelmed, and more hopeful. If you would like to volunteer to be part of this life-saving work, please visit our site to learn more about job opportunities. Next slide, please. This is our 988 website, where you can learn how to partner and market 988 from wherever you sit. You can use our toolkit, you can learn the data, the history, and of course, our findtreatment.gov locator, which is the second resource I'd like to share. Next slide, please. The first opportunity you see when you visit SAMHSA.gov is Find Treatment, with access to our behavioral health treatment services locator, a confidential and anonymous source of information for people seeking treatment facilities based on your location. There is an access to buprenorphine practitioners, educational information on serious mental illness, and the disaster distress helpline, opioid treatment directories, veteran crisis lines, and more. And I believe next year, SAMHSA will be launching a new and improved, more modernized locator site that is more effective and user-friendly. So Dr. Weiner, hopefully we can do this again next year. There's a lot of momentum in the area of wellness across HHS, and we implore you to please use these resources and share them widely. You can also sign up on any of our web pages for grant opportunities, like the Recovery Innovation Challenge we just held. Next slide, please. Just quickly, as Donna mentioned, the Office of Recovery, which held the first ever Recovery Innovation Challenge, where up to 10 community-based organizations will share a $400,000 purse. So please take a look to see which agencies could be located near you. Last slide, please. Lastly, I'd like to recognize Recovery Month this September. Here and now, Recovery lives with every person, every family, and every community. We believe that health, home, community, and purpose contributes to the success of a person's recovery, and every person has the ability to make a difference. And as my friend Val mentioned, it's about time. Thank you all for a fantastic afternoon. I'll now turn it back over to Dr. Weiner.
Great, thank you so much, Taylor, for everything. Sincerely, made this happen. And our last presenter is Gloria Brand. Gloria is the wizard behind the curtains today. She's the director in the program of an opioid and pain innovation at Brigham Women's Hospital. has a long-standing history of working with at-risk populations. She'll be discussing mental health screening, suicide prevention, and continuing education from the American Academy of Addiction Psychiatry. To Gloria.
Hello, everyone. I'm Gloria Brand. I'm the Director of the Program in Opioid and Pain and Innovation, as Scott mentioned, and I work alongside Dr. Weiner. Wanted to give a great big thank you to Dr. Weiner, along with Patrick Kennedy, along with Dr. Gandotra, along with Dr. Sherry, the entire SAMHSA CDC team, all of our panelists, and a big thank you for the bravery to our spokespersons today who live in recovery, as well as our very prestigious speakers today who were our keynote speakers. We really appreciate the time that you took today to add to this wonderful occasion and to give so much wonderful and pertinent information to our audience. I wanted to piggyback on what Taylor was talking about in terms of resources for today, in terms of just what you can do to further treatment resources, as well as offer those to not only yourself, your constituents, your family, and your friends. We encourage you to go to our website on Poppy. For those who are watching us live today, you should be able to access our webpage at poppy.bwh.harvard.edu, National Opioid and Substance Awareness Day. It will provide you with more resources on how to screen for not only substance use misuse, or to screen for suicide prevention, as well as screen for mental health disorder. On that same page, you'll be able to click into what Taylor was talking about with the 988 information for suicide hotline, as well as the treatment locator on how to find services for you, family, or friends. And then for our professionals on the line who are really interested in furthering your CEU, we have AAAP, one of our wonderful partners today, who are offering CEU courses. So please feel free, again, to go to our website, which is poppy.bwh.harvard.edu at National Opioid and Substance Awareness Day, and you'll be able to access those CEU courses as well. And so I'm going to put those in our comment section. And if you have any questions, please feel free to reach out to the Poppy program, which is also accessible at poppy.harvard.edu. And I'm going to turn it back over to Dr. Weiner.
Thank you, Gloria. So just to come a few final reflections. You know, I often look at the CDC statistics around overdose-related deaths, and I unfortunately have seen far too many of them in my clinical practice. And it feels like shortly before the COVID pandemic came, we kind of plateaued with the number of people that were dying from this disease. And I felt a glimmer of hope. It was such a tragic number that was being lost, but it looked like we had reached the peak. And then of course, COVID came along and just wreaked havoc on everything, on all of our lives. And the numbers of overdose deaths just shot up again. If you do look at the most recent data from the past couple of months that have been available, it looks like we started to see a little bit of a decline again. And of course, we don't know if there's going to be a trend to that, but what I think we need is something that was shared in many talks today, is this concept of hope. And that's the last thought I'd like to leave you with today, is that we do this during Recovery Month because recovery is possible. And we hope that those who are struggling with substance use disorders can reach recovery. And I'm so delighted that there have been so many collaborators today from all types of government, society, walks of life, professions that are so dedicated to helping solve this problem, because we can solve this problem. We must solve this problem. With that, I again want to echo, like Gloria did, thank all the partners, all the speakers, the people with lived experience who shared their own experiences as well. So powerful. Thank you all for your attention today. And we're going to just end with a video from Shatterproof, which is another one of our partners. And then after that, we'll conclude the session. Thank you.
The National Addiction Memorial honors loved ones we've lost. We invite you to create a memorial in honor of someone you love who died from addiction. A memorial is a wonderful way to remember a loved one and their legacy. Visit shatterproof.org and click on the link that says Visit the Memorial. Once at the National Memorial, click Create a Memorial. Fill out the form by first telling us about your loved one. Fill in their name, date of birth, and date of death, etc. Next, upload a picture. The image should be of high quality such that it appears crisp and sharp. We recommend a picture on a 1:1 ratio, or square. Once uploaded, adjust the picture so that it is centered. In the event that you wish to raise funds in memory of your loved one, you can do so by selecting Yes. Lastly, review your memorial. Once you have approved how it looks, it will be added to the National Addiction Memorial. You will receive a confirmation page with a link to your loved one's memorial. From here, you can share the memorial link on social media, via text, or by email to your friends and family. The link will also be sent to you at the email you provided. If you have any questions or want to make edits, contact memorials@shatterproof.org and we will be glad to assist you. Thank you for entrusting Shatterproof with creating a memorial for your lost loved one. We are honored to join you on this journey.